I'll come and join me in my village then. You have a free chicken. I live on a poultry farm. Kumasi is not a village. I live in a village near Kumasi. It's traffic free. Traffic free. So it's good to see all of you refreshed and energetic for today's session. I had a good rest as well. Thank you so very much for the organizers, for the accommodation to the organizers. So, Mabel, we start again this morning. So, shall we start with an opening prayer? Who is praying for us?
I'll call on Madam Winnie Otu to do us the honors.
Shall we please stand for a prayer? Merciful Lord, we are grateful for this opportunity. We thank you for being with us yesterday. We thank you for how much we are seeing through the blueprints that we need as a country to be able to enhance care for our patients that have cancers. We thank you for bringing us up again together this morning. We ask you to lead us, help us to be able to really see through and be able to gather what will make Ghana do better when it comes to cancer care. In Jesus' name we pray. Amen.
So again, we'd like to welcome all those online. Are we online yet? All those online, thank you so very much for joining us. If there are any comments, remember to put it in the chat box and we'll read it, we'll monitor it. So to start off, we'd want to remind ourselves what happened yesterday through the journey of ensuring that a family who is suspected with any form of cancer, be it in a child or across a lifespan, is taken through the process from screening, prevention if possible, diagnostics, hopefully timely, and effective therapy. So we invite onto the podium ASP Theresa Safubunsu to help us recap what happened yesterday. Police ASP. You didn't see her yesterday in the uniform? She was looking smashing.
She has changed.
The uniform changes people. Yeah. You do concern kakra.
Thank you. Good morning. Here is a little recap of day one of the National Cancer Forum 2025. So, day one provided a rich and frank reflection on Ghana's current cancer landscape, highlighting progress, persistent gaps, and priority actions needed to transform cancer care. So during the opening highlights, and we had some keynote messages as well, both the Chief Director of the Ministry of Health, in the person of Mr. Desmond Boateng, and who gave a keynote address on behalf of the Minister of Health, and the Deputy Minister of Health, Dr. Grace Ayensu, emphasized that cancer is not only a medical problem, but also a socio-economic, political, and health security issue. They urged collective action to raise national attention to cancer care. The government's flagship initiatives, that is the Ghana Medical Trust Fund, also known as Mahama Cares, and the free primary health care were identified as important pathways for reducing the financial burden on cancer patients and supporting service delivery. We also heard patient voices and innovation in engagement. The inclusion of patient and caregiver testimonies was commended as an important innovation for this forum. It reinforced the principle that nothing for us without us, highlighting the need to anchor political decisions in lived experiences. We had presentations and technical insights. The WHO presentation provided a strong overview of global best practices and the 5 key pillars of cancer care, which were prevention and vaccination, early detection, timely diagnosis and treatment, palliative care and survivorship, governance and finance. All these offered lessons that will guide Ghana's national response. We also had a presentation from the Ghana Health Service, which contextualized Ghana's current situation and identified critical gaps across prevention, early detection, diagnostics, treatment, and palliative care, underscoring the need for stronger systems and more coordinated action. From the various discussions, the key emerging themes were: 1, to demystify cancer. Participants stressed the need for community engagement to dispel myths and encourage early health-seeking behavior. There were also topics on strengthening the health workforce, and health workforce development was central, not just for specialists, but also for patient navigation. We also spoke about the equipment and technology and integrated care. Issues of equipment availability, maintenance, and replacement were underscored. The need for integrated service delivery, effective partnerships, and strong data systems were repeatedly emphasized. Speakers also noted that Ghana sometimes makes decisions based on prophecies, highlighting the urgent need for data-driven planning. Participants agreed that palliative care should start at diagnosis, with greater attention to home-based models and regulation of home care. There was also a call to strengthen psychosocial support for patients and families and ensure the inclusion of traditional leaders. Discussions also revealed that cancer is financially challenging, even for wealthy households. Development partners affirmed that funding still exists. Ghana must demonstrate transparency and strong justification for support. Private sector entities, Roche, Pfizer, and other non-profit organizations like the City Cancer Challenge, PIGO, World Child Cancer, all can play a role in financing and strengthening cancer services. Sustainability of the Ghana Medical Trust Fund was a major concern. Stakeholders stressed that it must become a national initiative and not tied to a single government. We also had breakout sessions, and the discussions revealed frustration among participants who noted that Ghana has many policies and strategic documents that remain unimplemented. So the key challenges identified were that we have a weak leadership follow-through, there are gaps in training institutions, there is lack of consistent political commitment, and over-reliance on producing documents without ensuring execution. Participants were urged to push for continuous advocacy, political engagement, and accountability. We discussed something on prevention and early detection, and the debate emerged around prevention of childhood cancers. While some childhood cancers may not be preventable, participants agreed on the importance of early detection, the need for high-quality diagnostic equipment and maintenance, strengthening referral pathways to reduce patients' loss after diagnosis, collaborating with traditional leaders, spiritual leaders, community pharmacists, and early detection and awareness creation. Participants also reflected that the Ghana health system is designed largely for acute episodic illnesses, not for chronic diseases like cancer, that requires long-term care, proactive outreach, strong patient navigation, integrated infectious and non-communicable disease services. System transformation is therefore essential. So the closing reflection, the day ended with a gratitude to participants and reaffirmation that Ghana is at a critical turning point. For the first time, cancer is receiving presidential level attention. So with sustained advocacy, leadership, implementation, and collaboration, these are needed to drive real change. Thank you.
The salute crowd, no fee salute. He had. Thank you so very much. And of course, you had to use the word security, health security. Thank you so much. So we continue with our themes. As you realized yesterday, we started a couple of themes, and we continue off with our third theme for today. And when people ask me, what's the most difficult aspect of your work? I don't think it's about breaking bad news or telling a mom that, I'm sorry, your 4-year-old I can't cure, he probably will die. The most difficult aspect of the work I do is having so much and yet being starved in the midst of so much. Because you drop a patient in the middle of an ocean of a staff strength of about 5,200. And then you say, go and look for the neurosurgeon. Go and look for the imaging expert. Go and look for this person. So yesterday when we were discussing delays and late presentation, the greatest portion of our late presentation happens within the healthcare system. It is not before they come to us. And the worst part is when they come to the big teaching hospitals. Because the most difficult aspect of our work is working together. Having to coordinate people from different disciplines to sit around the table to discuss one patient or a family. Yet it is the most rewarding when you do it and do it well. Because at one sitting, you get a final effective and efficient solution, which is time-saving and cost-effective for the healthcare system as well as for the patient family. So for the sub-theme today, we kick off with harnessing multi-sectoral partnerships to accelerate prevention, early detection, and treatment. To start off, I invite my friend and senior, Dr. Eneskunedu Esiedu, to help us understand better what our national and inter-sectoral collaboration landscape looks like. Then he will follow that up with a panel discussion. He will lead that and invite the panelists, as we did yesterday. So, Dr. Esiedu, please.
Good morning, distinguished ladies and gentlemen. Standing on the existing protocols that were set up. So, Dr. Chair, I would like to take this presentation, and I think aspects of it were kind of discussed yesterday in connection with the fact that cancer care is not just the Ministry of Health and its agencies' business, and that it's also the business of every one of us, because at the end of the day, we may also be the same sufferers of that. So as you can see, basically I'll be talking about the national intersectoral collaboration landscape. So the presentation outline will look at, a bit of an overview, which we have done already, so I'm not going to go into that. But the importance of multi-sectoral partnerships in cancer care. We also look at the intersectoral collaboration landscape. Then we look at the key players. And I'll delve a little bit deep into a number of the public service institutions, and then also to expose us why each of the 22 ministries, in addition to the Ministry of Health, making 23 ministries, and their agencies have a role to play as far as cancer care is concerned. And when we extrapolate this, as far as the entire securing the human health is concerned, and then a few best practices and some recommendations. And that recommendation would present itself as a question, and will bring the panelists here for us to discuss. So generally, we would say that there are some benefits as far as multi-sectoral collaboration or partnerships in cancer care is concerned. And we are looking at aspects of it that would look at improved cancer awareness and education. Yesterday, we realized that a number of institutions outside of the health sector would have to play a lot of role. Enhance access to screening and diagnosis, increase access to treatment and palliative care, and then also there should be some kind of better coordination and efficiency that will ultimately lead to increased funding. Again, with the presence of GRA here, we got that exposure that, you know, there's an opportunity for us to mobilize additional resources. Even he told us where we could even get some additional resources because we are thinking about sustainable financing. And then we can also leverage on technology, innovative financing models, and all the other things that are available. So if you look at the key players, generally we are saying that it encompasses everyone, and we are categorized either within the public sector space, for example, the Ministry of Education, Ministry of Finance, you know, because they were also represented here, the private sector organization, including the pharma companies, and then also private health insurance, you know, institutions, because we are talking about financing. Civil society organizations are also here, and then international organizations. Yesterday, WHO gave us the global and the regional perspective of cancer. So if you look at the public service institutions, which I'm going to focus more on, because when we get to the other, during the panel discussion, the civil society and the other partners would also expose us into exactly what they do. So when you take the Ministry of Health and Agencies, basically our major role is to develop and implement national cancer control policies, strategies, and programs. Ghana Health Service made a presentation as far as the program is concerned, and then we looked at some of the aspects of cancer prevention and control. Ministry of Education and its agencies have a major role, Ghana Education Service. The good news is that maybe a chunk of over 80% or 90% of the population will find themselves in the school, you know, right from childhood. So that gives us a very good opportunity to say that if we want to introduce things around awareness creation, we can catch them within the Ghana Education Service institutions that we have, both the public and the private. And that also will give the opportunity for us to incorporate cancer education into the school curricula and also promote awareness. In fact, I heard a story that there was a lady who was diagnosed of breast cancer, late stage, but she was in the university and she didn't know anything about that. I found that a little bit worrying, but they also told me that it means there's an opportunity for us to do a lot of work, because if we have a population of about, say, 34 million, and you reach out to, let's say, 1 million, you still have 33 million that you need to speak to or you need to educate. Now, Ministry of Communication, Digital Technology and Innovation, we also want to leverage on the technology for cancer awareness, education, and telemedicine, and then disseminate cancer information and awareness messages to the public. I mean, I'm sure when we watch the TV, there will be something that is usually running under it, some kind of stories. Could we work closely with Ministry of Communication to ensure that some of these things that are running, if you are 40 years old and you're a man, have you done your PSA? If you are, you know, have you done any clinical breast examination in the last year? Have you checked your, and not just for cancers, but for almost all the communicable, non-communicable diseases. Can we work with them to do this? Because they own or they regulate basically the various media houses and then also the telcos. Again, some experience that I found when I was in Korea was that at any point in time, you can get a certain message, you know, telling you that that part, you know, there's an accident there, so you can't use that road. And it's not like the one that we share WhatsApp messages. And you don't even have the network, and it will come as an emergency message, and it gives you an... Can we work with them, Ministry of Communication, so that, you know, they can also assist us in this using the telcos? And that will keep us reminded of some of the things that we need to do. If you look at Ministry of Local Government, Chieftaincy and Religious Affairs, today, again on the panel, we're going to have the Imam, we're going to have the Christian Council, we're going to have the traditional persons around. So they also support community-based cancer initiatives and services, and they use the community structures through the assemblies. I think a colleague of us talked about when you were, you know, working in the assembly also, and talked about the opportunities that we can get when we work closely with the assemblies, you know, to improve awareness creation and all that. So again, Ministry of Gender, Child and Social Protection, they also have a big role to play. They also address some of the social determinants of cancer and support vulnerable populations. Ministry of Tourism, we can use that opportunity to also advance and promote cancer awareness through culture or cultural and tourism activities. Then Ministry of Youth and Sports, we engage the youth in cancer awareness and prevention initiatives. For example, we organize a walk, and the youth, the energy in us is so much that, when we go for some of these activities. And then that is also an opportunity for us to discuss some of these NCDs, including cancers. Then if you look at Ministry of Finance and its agents, yesterday we were blessed to have the commissioner from Ghana Revenue Authority exposing us and giving us the opportunities how we can also mobilize resources, and then also the allocation of funds for cancer prevention, treatment, and research in the country. Ministry of Food and Agriculture, promote healthy diets and reduce exposure to some carcinogens in the foods that we are eating. For example, palm oil. We go to the market and then we want to buy palm oil. We say, oh, mommy, there. It's not red, cry. Then they say, oh, really? You want the red one? Thank you very much. The next time is adding the Sudan 4 dye and makes it red. Then when you come to the palm oil is red. But we do know that it's also carcinogenic. So that kind of awareness is important, and Food and Drugs Authority, which is an agency of the ministry, working close with Food and Agriculture, ensuring that the foods that we eat are less exposed or they have no exposure to some carcinogens. The Ministry of Environment, Science and Technology and its agencies also regulate environmental carcinogens and promote environmental health. So they need to also be aware as we work closely with our various partners to know that if they play their role, ultimately the burden will not end up. Ministry of Lands and Natural Resources, I guess we've been discussing a lot about, damaging our water bodies and the land. Not too long ago, I heard that some of the products that we export, for example, yam, the amount of heavy metals that are deposited in it, and some other foods, cocoa and all that, very soon, once we hit the threshold, countries are not going to take our food. And not just that, but we too, we are here, we are eating that same food. So we get ourselves exposed to some of these risks, and then ultimately may lead to. Works and Housing also has water, and we know that our water bodies are also being contaminated. We are beginning to see some congenital malformations. We are also beginning to hear of some other chronic conditions that, we need to work together. The same thing for fisheries and aquaculture development. These heavy metals also get deposited in the animals that we eat, the fishes in the various water bodies, and we eat them, and ultimately would also affect us. And then Foreign Affairs also plays a very important role, collaborating with international partners on cancer research, capacity building, and resource mobilization. So clearly, you would see that each of the ministries, departments, and agencies in this country have a role to play as far as cancer care is concerned. Ministry of Interior and its agencies are also supposed to ensure that there's safety, security. You know that Ministry of Defense, Ministry of Interior, and the agencies were part of this fight against Galamsey and its impact. So each one of them has a role to play. And also roads and highways, making sure that some of the risk factors, currently we still build some roads, we don't create opportunities for people to walk, we don't create opportunities for people to ride, and then these are risk factors to NCDs and also other carcinogens that may. So there are some best practices that we could work with. Most of the policies that we develop in the Ministry of Health, there's always a chapter called implementation arrangement. And this implementation arrangement gives that opportunity for clear communication and coordination so that each of the institutions will know their mandate, apart from what established them as law, that the focus for which they were established is to secure the human being. And that part of it, I think that is very important that we continuously have some engagements like this. Then there will be defined roles and responsibilities, and then also mutual trust and respect. Because, for example, I keep saying that maybe even when we ask of the 15%, the Abuja Declaration for the health sector, I mean, sometimes I take a risk and say that maybe we need just 5%. Because all the other ministries, departments, and agencies, if they play their role, what will be left will be the creative part. And that will look at infrastructure, take care of our human resource, that was supposed to provide the service. But sometimes we may be taking the money for, let's say, promotion. And apart from developing the content of what we intend to do, the rest of it, in terms of the dissemination of the information, we have to work with other ministry departments and agencies. If some of that money is given to them for them to do that particular work, it might not necessarily come back to the Ministry of Health. But we may take all the 50, we may even take 20%, and might still not be able to be very impactful as far as this is concerned. So let's look at these opportunities. But one of the challenges is also that mutual trust and respect where we can work well. And then we can ultimately do some regular monitoring and evaluation. So all these that we are talking about, mentioning all the ministry, department, and agencies, their roles and how they can work, it looks so beautiful, but of course, it goes with some challenges. For example, coordination. Even for us within the health sector, sometimes there are some challenges, and one of the conversations we had yesterday was also looking at governance, leadership, and coordination-related issues. So we need to look at this and see how we can address that. Information. Sometimes we do not know that the reason why the Ministry of Roads and Highways was established is to secure the human being. And if they are securing the human being, it's not just building the road, but we're building the road in a way that will benefit the human being. How do we disseminate some of this information? How will the final repository of outcomes of road traffic injuries, be able to communicate this to the other ministries to know that if they play their role well, ultimately the human resource that will require for, let's say, orthopedic surgeries and things like that will not be so burdened. Funding is also another thing. Yesterday, with the communication that we had from Ghana Revenue Authority, it told us that there are opportunities. We need to invest into our own health. And so if there is an opportunity for us to commit aspects of the monies that we have to secure our future, I think with understanding and with a lot of information, people may be willing to do this. And then infrastructure, and finally, the human resource, including humans, the resource including human and material resources. So there are some recommendations that we ultimately are thinking around that. Some policy recommendations for strengthening national and intersectoral collaboration in cancer care. We know yesterday there were issues around the doors of the ministry not so open, for which reason some partners find it difficult to come to the ministry and maybe may go directly to work with the communities. And that, we may miss out on where we intend to get to. So again, yesterday it was very obvious that we need to open our doors, be able to receive various partners who want to come. Then we can also guide in the way that work should be done efficiently. And then ultimately, we're looking at some suggestions for improving coordination and communication among the stakeholders. So when we get to the panel stage, one of them will be looking at those suggestions that we can work together. I'm hoping and pleading that this meeting will not be one of the usual meetings. It's not going to be a 9-day wonder. When I look around, I know personally over 80 or 90% of the participants who are here. Some were my teachers, some are my colleagues, and in the span of 3 or 4 years, they were all my colleagues that were in school together. I was having a conversation with one of my colleagues, saying that the future that we have been looking forward to, the future is with us now. If we are not able to do anything now for ourselves and to harness the opportunity for the next generation, our time will go, or our time will pass. And then we will now come and fall back in the generation or the group that will be looking back and saying that nobody is doing anything good for us. So I believe strongly that with this, and with this intersectoral collaboration and the conversation we are going to have, this is our best time to be able to put systems in place that ultimately will benefit us when we are old and also benefit the next generation that is coming. Thank you very much. So we go ahead. Okay, so we will quickly go on to the panel discussion, and then we try to mobilize various stakeholders who are here to be able to sit on the panel. So on that panel discussion, we want to call Ministry of Education or Ghana Education Service to take their seat. As they come, we can be putting our hands together for them.
So someone left the phone at the cafeteria behind us. So if you've checked, if your phone is lost, it's found.
Thank you very much. And also, Ministry of Environment, Science, Technology will be represented by Environmental Protection Agency. Please, can you take your seat? We also talked about the role of the Ministry of Local Government, Chieftaincy and Religious Affairs. And we are blessed to have a representative from the Imam to take his seat. When they sit down, before they start, they will introduce themselves and they will know the eminence that is following. This man is representing his eminence, isn't it? Okay. So we also want to call Reverend Dr. Ame, representing the Christian Council, because they also, let's put our hands together, because they also, you know, yesterday we had conversations around the church. So they should remember that if they don't see us in church, they will follow us, not the envelope or the check. Reverend Ame, you may please come through here, yes. Civil society organization will be presented by Dr. Riafe. Let's put our hands together for her. And then also international organizations will be represented by one of our colleagues working with Siemens. Please take your seat and you do the introduction here. Oh, let's put our hands together for the participants who are coming. And then I will call and then Arepi. Arepi will be represented by Philip from Pfizer. So that's the pharma, the Innovator Pharma Group, not the generic. Innovator. Anytime I say we shouldn't be writing that one. Very purified, you know. Okay. All right, so I'll join you guys there. Okay. So, nobody can see me. Okay, maybe then I'll start. And please, can you see Philip? No, please, maybe we may have to move them. Because when they are speaking. Okay, thank you very much, colleagues, and you are most welcome. Please, when you take the microphone, you do a proper introduction of yourself, and then you can speak. So, I think based on the presentation that we listened to, we realized that cancer care is not only the work of the Ministry of Health and its agencies. Of course, we lead it because at the end of the day, we become the final repository of diseases. So clearly, we understood that the work of managing cancer, globally or even in Ghana, is not only the work of the Ministry of Health and its agencies. It becomes evident because at the end of the day, the disease, as we see, and ultimately the other D that we do not want to hear of, which is the death, would happen within the health sector. And that is one of the reasons why the lead institution ultimately becomes the Ministry of Health. But we do know that if all the other ministries, departments, and agencies play their role in the way that we have seen now, and then they are also educated to become fully aware that the mandate for establishing them is because we want to secure the human person, then we can have a very good conversation, have a very good plan, and ministries and departments and agencies will play their role and take good care of the other aspects of the prevention and the promotion components of the health. And then ultimately, even as far as the curative part is concerned, we still need some financing and all these other things to sort ourselves out. So I will start with Ministry of Education, knowing very well that we had a free basic education. We also have free SHS. That gives the opportunity for maybe 80% of the population to come in contact with school. And we do know that a lot of the things that happen to us, we learn a lot of things from school. Can you tell us a little bit about what the Ministry of Education is doing, or Ghana Education Service is doing, in line with promoting health, and for that matter, specifically cancer care. We know that, yes, you have even gone ahead to take care of aspects of the creative care, but the one that we need to become aware of, can you share a bit of light on that? Introduce yourself first, and then you can speak.
Thank you, Dr. Asiedu. I am Desmond Ali Al-Hassan Kasanga, in charge of cultural education at the regional level. Once again, Dr. Asiedu, I want to say I am very small to talk for the Ministry of Education. However, I think I'm more than 20 years in GS. So with my little experience, I think I can do something about your question. Good. With GS, we know we are an agency under the Ministry of Education, as well as NACA, National Council for Curriculum and Assessment, deals with the curriculum development and the rest. Luckily, I was privileged to be part of the panel for developing the new curriculum. The new things that NACA has brought in, that has a link to what we are trying to discuss, is the introduction of the creative arts and design, right from creative arts for KG through the primary 6. And then the moment you enter into the JSS, you are introduced to creative arts and design. It is these areas that you have the performing arts, which will help in propagating the ideas of this cancer and its cure or prevention. When you move to the senior high school, you have performing arts now as a full subject, elective subject that students will undertake. And I'm foreseeing that with this, so far as mass communication or creating awareness is concerned, this can support to actually propagate this prevention and all those things that we are doing. However, with GS, we still have STEM, which is the science side of these things. We have coordinators all over the country, so they could play a role in solving some of this or to promote awareness. Then the cultural education unit. This is the side or the unit that we don't actually make use of. The cultural education unit has to do with creating programs to educate, creating platforms where students will exhibit their talent. So if the cultural education unit is actually involved, the Ministry of Health can decide 1 year to use to engage the unit, to use the whole year to engage learners to work on how, it's a whole, you can give a theme, and then the unit will pick it up and use it throughout the year. We start from the schools, circuit level, to the municipal level, to the zonal, there's some regions, then to the regional before we get to the national. Can you imagine if Ministry of Health decides that this year we are going to involve the cultural education unit of the Ghana Education Service to propagate prevention of cancer through their activities? By the time they will hit national, every child will be aware. And definitely when the children know, the mummies and the daddies will get to know. And so this is the little that I have from the Ghana Education Service side. And in all, that's the Ministry of Education.
Thank you very much. Thank you very much. I'm also very much educated in these things. So we will take it up. You know, this platform or this meeting is just opening our eyes to where we need to harness opportunities from. So I'll jump you and then also come to the Ministry of Local Government, Chieftaincy, Religious Affairs. I think currently the sanitation is also located there. So I'll take the first one from the Imam. Currently, we know that chunk of the population, and Ghana is a very religiously diverse group. So if you are looking for a Ghanaian, you may find him at one religious setting or the other. So we know that the religious groups hold and are very powerful as far as the population is concerned. We want to find out from your side, based on the presentation, what is the religious group doing to be able to propagate information around cancers, and then also educating our members to continuously do the preventive things around early detection, screening, so that people can take care of themselves, and that the other side of it, or the West components, will not also come.
Thank you for
introduce yourself first with His Eminence and thank you very much.
All right, let me thank you first before the introduction.
Yes, please.
I thank you for the opportunity to be here. I'm your humble servant, not your eminent. I'm Dr. Mohammed Marzouk Abubakar Azindo. And let me clarify that I do not handle the health of human beings. I do handle, as a doctor, the health of books. So I'm not a medical doctor. That's exactly what I am saying. So I'm the personal assistant to the National Chief Imam, and we are happy to be here. Let me emphasize the point you've made. Ghana is not a theocracy. We know Ghana is a secular democratic state, but religion finds expression in our nation building, in our governance, even in our politics. And to involve us in an issue of national importance like this one is commendable. We all know very well that Ghanaian is highly religious. Maybe that's why our national anthem starts with God. God bless our homeland, Ghana. And our national pledge ends with God, and so help me God. The 1992 Constitution in its preamble mentions God. So we are very godly, in spite of our constitutional democratic status. At the Office of National Chief Imam, we emphasize the health of human body and the dignity of human soul. And therefore, we do collaborate with even the Ministry of Health, but we have been very instrumental in the awareness creation about the HPV vaccine and the launch of the awareness creation about the cervical cancer. We've done a lot with the Ministry of Health, and we have a complete health desk. We know our limitations. We know very well that ours is health literacy, not health expertise. And we do also understand the symbiosis between health as science and religion. And we try as much as possible to let people understand that, yes, spirituality has a role to play in health, but spirituality should have a limitation. In a situation where spirituality is not well understood, even if it is impactful, it's not well understood by the people, then it must give way to science. And Islam understands science as part of the body of knowledge. So we are not anti-science. We are very pro-science. We know very well that science should be allowed to be used as a tool to solve problems for us. So at the national level, we are doing a lot. At the regional level, we have instructed all regional imams to dedicate sermons, particularly the Friday sermons, on issues of national importance. So anytime at all we are celebrating anything in relation to health, for example, when we had the opportunity to launch the cervical cancer vaccine, we instructed all imams in the country to dedicate their sermons on, because we didn't want a situation where we would record a vaccine hesitancy. We also didn't want anybody to subject that beautiful project to misinformation and disinformation. So we made it clear, but we also know our limitation. Ours is just to get the data from you and then disseminate. We are not experts. We are humble enough to know where we can start and where we can end. And one thing I want, the Imam has instructed me to tell you that anytime at all we gather here to undertake an important national project, we should be very realistic. Excuse me to say, with all due respect to politicians here, we shouldn't behave like politicians who promise more and deliver less. So let us be realistic enough to discuss what can be achievable, what can be implemented, and inject the highest sense of sincerity in handling that project. We are also of the view that no section can do it alone. We need to collaborate. But we also need to know specifically what various institutions can do so that we do not create disharmony in the name of harmony. We try as much as possible to come together and make sure that every institution plays its role to achieve this laudable objective. Let me conclude by saying that we also need data. We need data for analysis, for monitoring, for evaluation, so that we'll be able to be guided. And when we are guided, we can do more. My last point is interfaith approach to this project. Christians are working, Muslims are working, traditionalists are working. Yesterday, the idea of working in silos featured prominently. I am proposing, this one is not from the National Chief Imam, it's I'm proposing an interfaith approach to this awareness creation. Thank you.
Thank you very much. Let's put our hands together for him. So he says that the content must be developed by the Ministry of Health, and then it is passed on, but we can all do it together, and then you'll be able to disseminate it to your members. Thank you very much. So let's also take the perspective from the Christian Council around the same conversation we are having. So, Reverend, you introduce yourself and then.
Thank you very much for this great opportunity. But before I say anything, permit me to do some confession. In the first place, I was scheduled to attend a different meeting yesterday. I had the invitation to be here on Monday. But because of the experience I've had personally with some cancer patients of my own congregation, made me to cancel that particular meeting and to be here yesterday and today. I want to say that the religious nature of our country is also poses about 90% of our problems when it comes to healthcare. Why do I say so? Our religious nature makes us to think that anything that happens to any individual has a divine causation, whether it's through benevolent spirit or malevolent spirit. So our first attention to seek care and help is to think that what I'm going through is spiritual, and therefore I must look for help spiritually. And then, unfortunately to say, many of us pastors, I don't want to talk about imams, many of us pastors think that we can also handle cases that have to be handled scientifically, and that it will go. Instead of us referring the people to the professionals, and then we give the support that we have to give, we don't do that. Why? In the study of the New Testament, we have what we call the syncretism. Syncretism is the belief that you transfer your primary belief into a newfound faith. So whether we like it or not, all of us here may be migrating from one belief to the new belief in which we are. I was born in the north, precisely in Tamale. And I know there are many Dagombas who are traditionalists than being Muslims. So to become a Muslim, the person may be transferring some of his belief as traditionalist into the Islam religion. So it is in the Christianity. Whether you like it or not, you didn't come to meet your grandfather or your fourth grandfather who was a traditionalist. But that belief is inborn because they transmit that belief to us through proverbs, through stories, and we inculcate them within ourselves. So syncretism has become part and parcel of many Christians. Instead of me believing that now that I am a Christian, whatever the problem is must be handled that way, I want to believe that first and foremost it is some Satan somewhere, some witchcraft somewhere that is hunting me. So I must look for solution. I'm saying this sadly because I have lost 2 of my members, congregational members, this year from breast cancer. And the third person who is privileged enough to have all her children in the United States. They've come for her and she's undergoing treatment in one of the biggest cancer centers in New York. And anytime I call her twice in a week to check on her to see, because of the experience I had with the 2 people who have already died. And therefore, I have developed something for myself, what I think the church can be doing for people with cancer. And for that matter, any other non-communicable disease. And I think that the church can adopt 4 thematic areas to address the problem. In the first place, because of syncretism, we as a church must develop some spiritual support for them. Because without that, they can't believe that the church is with them. And therefore, what the church can only do after convincing the person to seek professional help, you can also guarantee that I want to work with you along this line, and therefore give some spiritual support to the person. Another thing is the communal support. Some of them, as we heard yesterday, the disease is very expensive to manage, and therefore many people, and for that matter, their parents and their families and their friends, in one point or the other, you become fed up. And that is the time the person will need the church most, so that we can even sell whatever the person is going through and seek other support. Because when somebody is going through some pain, and you can only go and sit down with the person and not offer anything, but that to show a sign of acceptance and also be able to talk with the person, spend some quality time with the person, that alone is a healing balm, a healing process to the person psychologically. Then the third one is education. I think many of us, pastors, here too, let me say, that at the Christian Council, you know that we have a health department, which is known as the Christian Health Association of Ghana, the CHAG. But we are yet to establish advocacy department to be able to go around, educate, and actually let people understand some of the non-communicable diseases and how it impacts on the people and what we should be doing as a church in support. That is yet to be established. So I think that we need that education, that people will understand what cancer is all about, the different forms of cancer, and the things that people go through, and what we can do, even though we are not medical professionals, but we have a role to play to cause total healing for the people. And the fourth is the advocacy, that we will let people understand.
This will really, really work well for us. Okay, so we'll quickly move on to civil society. Yesterday, we had a lot of conversation around the role of the civil society. So, Doctor, please introduce yourself, and then we'll give you 3 minutes, please. As for Reverend, because he's preaching, so I had to signal him that he's preaching. Thank you very much.
Thank you.
In civil society, this is what you do all the time, so 3 minutes is fine. Thank you.
Thank you so much. So I am the CEO of the Peace and Love Hospitals, Beatrice Uafe Adai, the president and founder of Breast Care International, the chairperson of the Ghana NCD Alliance, and the founding director of the Otumfuose II Comprehensive Cancer Center of Excellence. I must say that transforming cancer care in Ghana has been long overdue. If previously we thought that it was that woman's problem, that person's problem, unfortunately now it has come so close to everybody. Cancers have become so close to us, so personal. So it has made the work of advocates easier. And so I think we should look at some civil society organizations who are doing a lot globally and see how we can also emulate the examples. We don't need to reinvent the wheel. If you think about UICC, the world's largest cancer organization, it's a civil society organization. NCD Alliance is also a civil society organization. CCAN, it's also a civil society organization. So let's see what the advocacy that civil society organizations are doing. Let's look at them as the consumer protection agency in our communities, because most often they are in the community. They are working with us and our people, especially those who are in the hinterland. They are the mouthpiece of patients and survivors. They can be used for so many things. And I was hearing that sometimes advocacy or education and awareness creation can be loud. You cannot change people's perception when you go and whisper into their ears. Sometimes you have to use the vuvuzela for them to hear what you want to say. Because at the end of the day, they will end up in the hospitals when it's too late. So why don't we start shouting if we need to? Why don't we educate our people? I'm happy we have all the stakeholders here. And if the pastor is saying that they have a role to play, we, the CSOs, are ready to work with them. We are already doing that. But unfortunately, we have a lot of cancer patients hiding in the prayer camps. And for breast cancer, they start coming out after October, when we've done a lot of noise making. So let's see it as a joint venture. Let's not see it as somebody's problem. Let's learn to work together. If in a community there's no cancer treatment center, we can have community leaders, civil society organizations who are there, who can help be the bridge where we can support the patients and survivors in the community. We don't have to allow people to suffer alone when it comes to cancer fights. We all know that it involves a lot. The patient, the family, the caregivers, and the fact that we don't have any support system, social support system, is something that we should look into critically. We advocated that we should put cancer patients on the LEAP program whilst they are taking their treatment, and they have to travel every 3 weeks for their chemotherapy. Can't they get some support from the LEAP so that when they are done with their treatment, they go off it, and then some new people can come onto it? There are some things that we can do within ourselves without going for even external funding. So let's see how we can, this critical roadmap, which will lead us to sustainable prevention and early detection measures, equitable treatment. It doesn't matter where the woman is living. She should get the same treatment that the one living in Accra is receiving. Why should it differ? Because of geographical locations. And civil society is the mouthpiece that can make this happen. Let's not see civil society as antagonist. No. Let's see civil society as the catalyst or the conduit that can help us make all the efforts we are putting in place work. Academia, the ministries, all the stakeholders, so that we can have a seamless transition into a better cancer control system.
Thank you very much. I was trying to whisper into your ears, but it was not working. So I had to use the vuvuzela. Thank you very much. I think it's very important. We need to talk about it all the time and make noise around that. Oh, you have your microphone. So I want to know, we have EPA here, and they also are supposed to take care of the environment in a way that some of these carcinogens, whether they enter into our water bodies, whether they are in the air, they find themselves in the soil and end up in the food that we eat, everything gets into the human body. What is the role of EPA based on this conversation we are having, so that in terms of primary prevention, secondary prevention, you can assist, so that they don't get into the place where we don't want them to get to?
Sure. So my name is Harriet Naili Hammond. I'm a health professional, and I'm also in charge of the Occupational Health and Safety Department in the EPA. So per our conversations about cancer, it's obvious that the EPA has already been playing a critical role. The only difference is that we haven't actually communicated the health link it has. So everything the EPA does is about health, but probably the collaboration and the communication and the public education on the reason why we do what we do hasn't been communicated adequately. So EPA, for instance, air control, as he says, we have a good collaboration with Atomic Energy, where we control the amount of air pollution that is being produced. We do permitting, where we regulate the kind of waste that companies produce. And in all these things that we do, we are aware of the health implication that it has. And then cancer, as we know, in as much as we don't have a specific cause, we know air pollutants and all the radiations and exposure are all causes of the cancer that we experience. In recent times, the EPA has introduced e-waste management system, where we now make sure that electronic waste, which is also a cause of cancer, is discarded in an appropriate way. And then the fight against the illegal mining, for instance, it's been on and on for a while, but I think that we have actually intensified the fight against illegal mining by actually going after the production companies of the champagne that they use for the production of the machine that they use for the illegal mining. So these factors, air control management as well, the air monitoring system, we have enhanced communication. Just like I said, we probably haven't collaborated adequately with the Ministry of Health on some of these discussions. But when it has to do with prevention, regulation, and then education, we've focused on educating the public on why we are doing what we do, but we haven't linked it to cancer itself. So I believe going forward with our presence here is an awareness, and it's a beginning of a beautiful relationship in cancer prevention. Now, maybe when we are speaking, or we could come out with a roadmap or a relationship where whatever we do, we would highlight the role in cancer prevention in the public. So when we are dealing with our companies, our mining institutions, our manufacturers, whoever we deal with, air control systems, we would try and highlight or make a point around cancer prevention. And then in future, we could have a collaborative program together to raise more awareness for cancer prevention.
Thank you very much.
Thank you.
Thank you. Let's put our hands together for her. So from this meeting, we are having a very good relationship with EPA.
Yes, please.
Through maybe your ministry, and then we see how everything that you do for that reason is to secure the human person.
Yes,
Thank you
yes.
very much.
Thank
yeah.
you.
So we will take Philip. Philip will introduce himself. I think your name is a little bit like Pfizer. Philip will introduce himself, and then also, I mean, he represents Pfizer, but at the same time also represents another bigger pharma group. And then you can also tell us a bit about the role that they play. I know that it's profit, but you say something small about it. Thank you very much.
Thank you very much. My name is Philip Selassie Tagboto. I'm a pharmacist by profession. I chair AREPI. The full meaning of AREPI is Association of Representatives of Ethical Pharmaceutical Industry. It's an association that's made up of close to 15 multinational companies operating within Ghana. Our primary objectives include shaping policies in order to ensure equitable access to innovative medicines. We are also affiliated to an international organization called the IFEMA, which is a global organization of international manufacturers. Ghana is one of 4 African affiliated associations. The second is in Kenya, the third is in South Africa, and the last belongs to the French group. As AREPI, to achieve our primary mandate, how we can support is to continue engaging the Ministry of Health and other stakeholders to support initiatives around education, awareness creation, early detection, and diagnosis of cancers. And this we've done for so many years and will continue to do. I would like to highlight a few. My colleagues from Roche for many years have been supporting awareness, diagnosis, and treatment for breast cancers. My other colleagues in J&J for prostate cancer have been doing quite a lot. Pfizer breast cancer, and also last but not the least, AstraZeneca, when it comes to lung cancers, they've also contributed immensely. The second point I would like to highlight in terms of how we can support is to ensure that when therapies are available, they are also readily available in Ghana. Gone were the days where it took sometimes 15 to 20 years after introduction of a new medicine for it to get into our market. But today, we have therapies that are launched in Ghana same day as they are launched globally, thanks to the effort and collaboration with the FDA. And we want to make sure that when the best medicines are available for cancers, we can also have it available for use in Ghana. And many times, we are not just making them available, we are making them available at something we call internally access prices. Just to clarify what access price is, yes, it's for profit, but we are able to engage internally to ensure that if globally the price for a product is X, Ghana as a country, patients and doctors are able to get it for patients significantly lower. I have evidence to show that sometimes even up to 80% reduction in the cost of the medicines. And what I've observed is that often doctors are happy. Patients do not need to travel as far as Europe and India to get some of these medicines because they can be accessed locally. The last point I would like to highlight is partnerships to support, strengthen the health systems. It goes without saying that for many of the medicines that member companies have introduced, we need to support, build capacity of ACPs, either doctors, nurses, and also to a great extent pharmacists in the area of reconstitution, etc. And to this, we continue to collaborate and work closely with the GMA, Ghana Registered Nurses Association, and also the Pharmaceutical Society to ensure that this is done. The other point I want to highlight on health system strengthening is that in certain situations, we've managed to help establish cancer clinics in facilities that do not have it with our support. We've also collaborated to ensure that where there is a need, urgent need, we can support the training of medical oncologists. And it's worth noting that Roche has been supporting a lot of this for some time, and Pfizer recently got on board, and hopefully we'll have cancer diagnosis and treatment in some of the regions that hitherto we didn't have oncologists, like Volta region and also Northern region. Last point I would like to highlight on where we can collaborate to strengthen the health system is the area of clinical trials. In the past, when clinical trials are done, many countries in Africa are not considered. But today, many of the doctors here can attest to the fact that when the clinical trials are announced for specific diseases or new medicines, Ghana is included. This helps build the capacity of doctors participating. It also ensures that patients are able to access early therapies. And many of them, when they are part of these clinical trials, they do not pay anything for this medicine. This also ensures that patients are able to access. And even post these clinical trials, if there is the need for patients to get access to these medicines, there is a guarantee put in to ensure that patients get it. And this is what we want to do as members to ensure that we can support the care for cancer patients. And last but not the least, we to achieve all this, many times we are the Ministry of Health negotiating for VAT exemptions or tax exemptions in new molecules so that they can be relatively more accessible or affordable to patients, because it goes without saying, if we can reduce our medicines prices by up to 80%, if patients will still have to pay taxes on these medicines, then we are defeating the purpose for which these reductions happen. And this is what we would like to follow up with the ministry to get to done. Thank you.
Thank you very much. Thank you. Let's put our hands together for Philip. And then finally, we will take a global perspective of collaborations to improve cancer care. So introduce yourself and then...
Thank you, Dr. Anis, and thank you, Ministry of Health, for organizing such a great forum. I am a firm believer that solutions are usually within us. We just need to put our hands together and our heads together, and we'll have a solution that is long-lasting for Africa. So my name is Quinto Wonder. I work with Siemens Healthineers as Head of Government Affairs for Eastern Africa and English West Africa. So as many of you might know, Siemens Healthineers is a global medical technology company. And in cancer care, we pride ourselves that we have end-to-end solution in cancer care, from screening, diagnosis, and now treatment with the Varian radiotherapy solutions. So today, I know yesterday we had said that, don't tell us what you're doing in other countries, tell us what you're doing home in Ghana. But I believe that there is no need to reinvent the wheel when something is already working in another country. So I will just go into some of the partnerships that we have had in other countries that are working well, that we can also emulate in Ghana. One of them is SICAN partnership that SICAN was here yesterday. They talked about Kumasi, but not only Kumasi, they have other cities in Africa that they are working in. We have today a collaboration that is ongoing with World Economic Forum through their Global Alliance for Women's Health. And the reason why this is something that is worth mentioning in this setup is that we are working on cervical and breast cancer coalition, where different partners have come together to train community health workers. We started with Kenya as a pilot country. So community health workers are trained on advocacy on breast and cervical cancer, but also they're training the healthcare workers in level 2 or level 3 systems on LEAP, colposcopy, but also generally on screening of cancer. But that is not the end of it. Also, they are screening at the community level. The other partnership that I would also want to highlight is our partnership with IAEA. Recently, we donated a linear accelerator to IAEA. But that is not only partnership. Those are not only the partnerships that we have. We also have partnership on capacity building and training. I know yesterday we talked about, the gaps that we have on human resource for health and the gaps that we still have in terms of upskilling, even for the different cadres that we already have in our midst that are already trained. We know even the training gaps that we have in Africa. So we are working with the likes of RADAID to upskill the different cadres in radiology, and luckily, Ghana is one of the countries that we are going to upskill in this fiscal year together with RADAID. But also coupled with that, we are working with Road to IR, which is focusing only on interventional radiology. We are working with IRCAD Africa in Kigali, but training different cadres across Africa. We believe that we have to upskill the expertise that we already have in our system, but we also have to generally support the healthcare system and strengthen the healthcare system. Coupled with that, we also believe in strategic partnership. Yesterday, one of the gaps that was mentioned here, or the challenges that we have in our setup, was financing. We know that most of this equipment, as much as we say that in Siemens we have end-to-end solution, and another organization will come and mention the same, as industry, we have the solution. But the solutions are capital intense. So then how do we make them accessible, especially to our African countries? So we have worked on a number of strategic partnerships with different governments. We've worked with Rwanda, that is ongoing right now, to ensure that they get equipment, but not only equipment only, but they get equipment on deferred payment, and at the same time we train the capabilities that they already have in their midst. We have one that is ongoing in Zambia, looking at the linear accelerators and the linear accelerators and the brachytherapy. We know how capital intense that is. We have discussions that are ongoing currently in Nigeria, and the one in Nigeria is specifically closer to the discussion that we had yesterday on screening at the community level. Because if we wait for people to come to the hospital, the ones who will come are patients. If we are talking about cases are at the community level, and we have to start thinking of solutions like mammo truck on wheel, or mammo on wheel, which is a mammogram in a truck. And that is what we are exploring currently with Nigerian government. So all these solutions are, some of the solutions that we can also explore in Ghana case, and we are willing to work together with you. And I believe that is generally what the industry is saying, that we are open to collaboration.
Thank you very much. Let's put our hands together for our panelists. I will not attempt to. I think I've overshot my time by about 30 minutes.
As you can see, I'm sucking you.
Exactly. He had pity on me because, So let's put our hands together for the panelists, and you may take your seat. Thank you very much.
So, Dr. Chair, with your permission, please be careful. With your permission, I know we have a set of 3 broad discussions to look at after the health break. That sort of encompasses these first 2 panel discussions. So with your permission, just like I have seen you making copious notes, I'll ask participants to also make copious notes so that we spend more time on the discussion period with your questions. So we won't take questions for the panelists now. We'll do that during the query breakout period on the 3 discussions. Okay? Thank you so much. Because if you look now into the program, you can see that we will discuss treatment, strengthening oncology centers, human resource and supply chain. Then we'll also discuss palliative care, expanding home-based care and community-level integration. And then strengthening cancer data management, research and innovation, National Cancer Registry. So you see that those are issues that these two initial panel discussions will look at. So if you do have questions, kindly put them down. And that goes for our online participants as well, so that we can have in-depth discussions during the breakout session. But remember, there will be no physical breakouts. We just break them down into 3 main topics. So now we are going to talk about the big elephant in the room. We've all been designing theories, conceptualizing, and identifying so much in terms of implementation gaps. The evidence has been done. Sometimes we are fortunate to be part of this evidence process of making the evidence. The challenge has always been translating that or transportation into an implementation practice. And the center of all of that is quality information, quality data collected in a manner that is timely, that can track what we are doing for monitoring and evaluation. And you and I know that has been our greatest challenge. So recently, we tried in Confanochi to look at, so when we talk about cancers, everybody mentions breast. If you talk about child cancers, you disaggregate them, nobody talks about brain tumors. So when we started looking at them, apart from physically navigating these children, we tried to electronically navigate their records. And one night, I woke up and my electronically tagged records, I don't know where it is. Is it sitting in limbs? Has been retransported to games. Headaches. So we go on to sub-theme 4, leveraging data, technology, research and innovation for evidence-based, patient and family-centered and palliative care. To help us understand the current status of the Cancer Registry, digital tools and research, we invite Professor Joe Yanni to give us his presentation. Sir, you are welcome. Please, let's give a resounding applause to Professor Joe Yanni. We all heard him yesterday, so he's going to continue.
So, first of all, you pay a fine for changing my name.
Sir, how much, sir? I have a lot of people to help me pay.
No, I want it from you.
I come from the land of gold, sir. No problem.
Yeah, so my name is Joel. Joel. Yes. If you are a Christian, it's Jehovah El. Eli, Lama Sabachthani. That's where the L comes from.
Oh, Father.
Right, so we want to talk about cancer registries. And as far as I can remember, cancer registries have assumed status of like something that is a mystery for most of us, because it is like a moving target for us, an enigma. And for some reason, we are never able to get it right, even though I think we have all the elements to get it right. I hope that after this discussion, which I don't think will be too new, we will be able to galvanize ourselves into action. So, like everything, you need to identify the problem. If you don't identify the problem well, you will not prefer enough solutions. But so do we think that it is a problem? I think we do. We do know that cancer is a problem. But in defining it as a problem, we have relied mainly on foreign data. I'm not saying that it is not true. It is true. Foreign data is okay. It is right. But it is important that we develop our own data so that our conclusions, extrapolations will be more valid. So that during the process, we'll go through the project cycle, we'll do scoping of the problems to identify who, where, why, and so on. And that will involve data acquisition, data exploration, which is all related to the cancer registry, which we'll talk about. And then modeling. Modeling will help us to do predictions, predictions with regression models, so that we can predict what will happen and take necessary action. So the problem, we know that this is a problem. And to the extent that about 43% of NCDs is cause of death, 43% is NCD. But this, as I said, this data is generated from WHO. Recently, I'm told it's even 45. I'm more interested in the trend because in the year 2000, deaths attributed to NCDs was 27%. So in the space of 25 years, we have moved from 27% to 45%. So you see the trajectory. So we keep on moving. NCDs have become very important. And of course, cancer is one of the important NCDs, and we have to prepare to take care of it. The important thing to note is that the prediction models say that most of the increase will come from our part of the world. And they use HDI, Human Development Index, which is a score made up of a life expectancy, representing our quality of health, our GDP, our finances, and education literacy level. So Ghana will be somewhere between the low HDI and medium HDI, and the increase in incidence of cancer will be more compared to, even though our values are small, it will be more than elsewhere. The increase is about 99%, whereas in the developed world it's just about 42%, which is going forward, we have to brace ourselves for action. So this meeting is very important. Among all the factors that we blame for increasing incidence, which we talked about from yesterday, the most important, I think, in my opinion, is the life expectancy. The life expectancy is increasing. It's increasing. The women always live longer than the men. So people have realized it and are giggling. Perhaps the women kill us. Don't go to me anywhere, please. Yeah, but I think even at birth, even the boys die more than the girls, That was just a joke. But I just want you to take note of the increasing life expectancy because of control over infant mortality and so on. Yeah, but I mean, the point is made that we are an aging, even though we have very young population pyramid, is still, the shape has not changed much. Still, it has a wide base, but it's changing. So if we develop our own data, we will be able to ask, when we do problem scoping, we'll be able, because the data is ours, we'll be able to ask these questions. Who develops the cancer, right? And when? Some people have been telling me that our cases, we have more cases coming from Volta region than other parts of Ghana. Many oncologists have told me this. Is it true? We don't know. It's anecdotal. There are people in the room who have told me before. But it's just based on their experience. We don't have data. If we have data, we'll be able to ascertain whether that statement is right or not. Then we can tell. We can find out why that is so. So there are things that nobody can do for us. So it's important that we develop our own data. And the vehicle to accomplish that is a cancer registry, which we have attempted for several years. Let me say, here it has become a subject for us to talk about. It has only become a subject for us to talk about because there's something on the ground. And as far as I can remember, late 1990s, me and my partner in crime, Bafo, at that time, I didn't have much interest in it. But I think that prior to us going to South Africa, Bafo had been to Gambia. Gambia has a very good cancer registry. You see, so when we returned, and because he did oncology, we started something in Kolebu and then continued to Kumasi. That is the history behind. But the point I want to make is that it is born out of personal interest and not something that is coming from the ministry or some organization. And that is where I have a problem with. So we are in a situation where people want to talk about, when they have to present something, they need data quickly, and they come chasing you. What investment has the system made into creating a cancer registry? The framework, do they know who gets paid what? The people who work in the registry. Nobody cares about it. I have to cool down. Yes. Yeah, but it's a continuous process. We started it, but it has to point us to me. And it's systematic. Because of funding and all kinds of things, sometimes we will have help from NGOs. NGO assistance is very important. But for how long can you depend on them? They also have their own agenda. That is the truth. Nobody is Father Christmas. So the country itself should have a framework for all its problems, so that when people come to assist you, they come to fit in it. That is what should happen. It shouldn't be the other way around. In my professional life, I've seen it happen several times. People get excited that these people are NGOs. Once they leave, everything collapses. So we need a plan ourselves, you see. And so there's a feedback loop. There's a feedback loop between the data and prevention. Once we are able to do the scoping and so on, we're able to do feedback loop. And then, so policies regarding prevention, screening. What is screening? You see, when you are listening to some of the radio stations, you hear people talk about breast cancer. Oh, breast will be engorged, a bloody discharge, or ulceration, and so on. Why? By the time you present with those things, you are half dead. Screening is what? Tests performed in asymptomatic individuals. That is where you want to catch them. So once people come on air and start talking about symptoms, then it's a non-starter for me. And yet, that is what we are happy about. If we have good registries and we do things properly, there will be a feedback loop between that. So, yeah, so we have these kinds of population registries. So it is not to say that we haven't done anything, but to set the stage for today's discussion, maybe I'm being too verbose. Let me read from somewhere. See, the Globocan, this is 2018. The quality of national incidence data is scored from 0, which is best, to 10 worst. Ghana is 8. You see, some people see 8 over 10 and think that you have done well. In this case, 0 over 10 is better. So when we are around 8 over 10, it means that there's a lot of room for improvement. A lot of room for improvement. That is so. What are we doing to move from the 8 to maybe at least below 5? And I think that is why we are here. Someone will ask why the cancer registry. People have asked me before, because DIMS is available. Okay, this one I just put it in just for to remind me about the discussion. You see, so we are using DIMS. Okay, let's say in a peripheral site, and number of cases you see 2 million something. Then out of that you find only 2,000. Okay, what? Yeah, 2,800,000 something is excluded. Then you are left with only 28,000. You do cleaning the data, missing age and so on. Okay, so it means DIMS is useful. It has collected some data on cancer. So then we should jettison the cancer registry and just rely on the DIMS. Can't we do that? Another example, I gave forms of registration. This is a paper written by one of my teachers, Prof. Redu, and he relied on autopsy and death certificate. In fact, for a long time, we were quoting this. And this also gave us, good data, but we accept it as figures for cancer registration. Why do we need? So this it will be specialty, cancer registration will be specialty registration. Okay, so we are saying that we should be doing population and specialty registration and not just use DIMS and so on, because there are reasons for that, which I will adduce. And then we also are talking about population-based. We have data, all right, but I'll come back to the previous slide. But this is abstraction for Korle. In fact, what I'm presenting, I think it will apply to Kumasi too, so that we save time. During the discussion, if there are differences, there will be opportunity to fill in from the Kumasi people amongst us. But it's basically the same. So you see that this one, for instance, the abstraction form, it shows tumor record. This will not be, you can't get this from the DIMS. And it's giving you details of staging, laterality, pathology, and so on. So this gives you detail that you can't get from the DIMS. So it is very important. That is why we justify the need for a registry. Apart from that, why is it that we say, oh, we don't have a population base? People say, oh, you have it and so on. It's the way we get the data. Kumasi and Accra, we all started that way. Initially, it was institutional. But once we broadened the data source to using information from death certificates, autopsies, we go to a labs. You visit all the pathology reporting sites, you get data, you go to all the hospitals. You don't concentrate on only the hospital that you work in. Then it's assuming the character of a population base. And that is what WHO demands, that we have a population base. So we need a population base. We need a specialty registry, which is a cancer registry. And the topic I was giving is related to research. This one, for instance, was gleaned from data from our registry. And it's telling you the percentage of patients that get systemic therapy, almost 60. Without the registry, you couldn't have known this. This is telling you that most of your patients are advanced. In other places, the dominant one would have been surgery. But for us, surgery is just about 30%. Okay, so these are things that breast, if you put it together between stage 2 and 3 at presentation is 49 plus 38, which is what? About 87. So stage 2 and stage 3 breast cancer together is about 87%. This we get from what? Registry figures. And the beauty of it is that when we perform the same thing, let's say in 5 years' time, we do comparative studies, we'll be able to tell whether people are coming earlier or people are coming late. Okay, so this is all related to research and it's related to policy development. I made mention of death registry. This is Ghana's, it's a bit old, but I tried to look for newer data, I couldn't find it. But our death registration is very bad. So it means it will affect the quality, because your death certificates, you would have the cause of death on it, where you can get your diagnosis of cancer. It's in the cities that people die, in the villages, in the periphery, people die, they just bury them, isn't it? So it's all related. It's a quality thing. If we don't address all these issues, we have quality problems. So the Accra, another issue that distinguishes our cancer registry from the hospital or institutional based one is the jurisdiction. You see, so Accra, for instance, oops, what have I done? Accra, for instance, we trying to use the point. Oh, no. Let me go back. Okay, I was just trying to point out our geographical area. You see, unlike a paper that we publish, I'll show you. This one, we have defined the area. So Kumasi 2 does the same. You define the area in which you are operating, and it's divided into districts. So your denominator for calculating your rates is known. Okay, these are all distinguishing features from institutional registries. And I showed this just so that you see, Jesus is talking to the disciples and says, "Let not your heart be troubled." So our hearts should not be troubled when we have capacity that is not high. You see, because even in the US and other developed countries, you don't have registries in every nook and cranny in the country. Okay, so if we plan well and we have good geographical representation, I think it will suffice. Of course, the more, the better the accuracy. But then we cannot say that we are waiting to have registries in every district before we say we have a national figures. I think that if we position our registries in the teaching hospitals, the distribution is fine. We can call it a national registry. So you can see the color code there. You can see SIA in the US where they have registries. It doesn't cover the whole country, so we shouldn't be worried. I put this in this is a paper we published 2012. You see, it gave us figures all right, but then the denominator, this is called, the denominator was what? It's like OPD attendance. So, can you calculate your age standardized rate? You can't. Okay. So all to buttress the point that we need to do a population base. So for the other size that we are suggesting, you should have, the denominator should be known. You should map out the geographical areas we are dealing with. So this is data from the Kolebu Cancer Registry. And the figures, I'm not saying that GlobalCan is perfect, but our figures are almost the same as GlobalCan if you relate it to the HGI. And here, this is counter to the previous point I made. You have figures that are very different from the Kumasi one for some of the cancer sites, like cervix, for instance. Cervix, whereas we got 6.9, Kumasi had about double figures. So it's telling you that there's country variation, and unless you study it, you won't find it. So when we recognize it and we study it, then we can find out reasons why it is so. Okay? So it's important that we have our own. This is breast. I want to show breast is last but 3, C50. You see, the age standardized rate is about 16. Yet, if you Kolibu one is about what 28. So there's more breast cancer in Accra than Kumasi, and cervical cancer is the other way around. So why? These are things that we can find out. Digital dimensions. So my people, okay, so we use EMR, fine. So we are trying to use the EMR. The problem with this is that I'm sure the Kumasi people will give me their experience. We can glean the cases, fine, the diagnosis, that this is cervix, this is breast, and so on. But the details of, you saw the abstraction sheet that I showed, that we cannot get because the two processes don't talk to each other seamlessly. So it's something that I think we should work on. CanReg is the platform we use. Okay, I think we must also use the CanReg, but it doesn't talk seamlessly with the LIMS and now the games. Case identification, fine, it can do it, but we should have an electronic system that will make it easier to do the abstraction for the two databases to talk to each other seamlessly. It will make life a lot easier. And then the system of recording too. CanReg uses ICD-0, and then LIMS is using ICD-10. Okay, so these are issues that plus some other issues that I'm sure will come up in the discussion. We should sort out. The rest, I think, is pedestrian. Everybody knows about it. You collect your data, you do data cleaning. The most important is getting the data. The rest of the steps, I'm sure, straightforward. Yeah. I'm about ending, but just to buttress the point that in other places, this is from Europe, centers are certified. I'm talking about treatment now, based on information from the cancer registry, based on your fidelity to guidelines and so on, which they find out from the work that the cancer registry does. So you cannot, like head and neck cancer, for instance, very complex, and yet we see somebody in the, let me give you an example. You take you see a neck mass, and then you take a biopsy from the neck. The ENT surgeons will tell you that that is a no. You see, because the people in the periphery, anybody can do anything. In Ghana, anybody can do anything. So it affects outcomes. We need a situation where hospitals are certified based on data. This one, we were talking about neoadjuvant chemoradiotherapy. You see, so the data that the registry received, it was able to catalog the percentage of patients that had submitted to the protocol, that particular protocol. So then you give feedback. You see, so you have your guidelines, and the cancer registries, cancer centers working together using the data. How do you even call it? Triangulation. You see, so that the outcomes are better. So in addition to all that we've said, getting the data and so on, it will help us with policy development and also guideline modification. My registrars have complained to me that sometimes those days that everything was manual, you want to go to a department, you want data, and the people don't want to mind you. Okay, you go to surgery, the people are busy. Not that they don't have time for you; they are too busy, and people don't see it as part of their work. You see, it's like they are doing you a favor because we haven't put in place the structures. We haven't made it official that this is cancer registry. This is the work that they do, and in assisting them, it's part of the work that you should do. You see, we don't have all that. So it makes life difficult for the registrars when they go in. So we need to have a system. So, and that system requires a board, even at the local level, and I'm sure even at maybe at the ministerial level or so, whatever people may decide. So you have people from birth and death registry, for instance, represented. You have biostatistical services represented, because you want to calculate your age standardized rate, you need them. Okay, they will give you appropriate population pyramid so that you can compare to your standardized age pyramid and do the calculations. So in conclusion, we have 2 functioning population-based cancer registries, although there's room for improvement. Okay, we have multiple hospital cancer registries. That's what there are many. The institutional framework requires attention. I think I have spoken about that a lot. And the teaching hospitals possess the architecture to start this. So by this, I'm referring to the others, aside of Konfanochi and Kolebu. And the stakeholders, birth and death registry, all the pathology reporting services, wherever we can get diagnosis of cancer from. Okay? And the deficiencies in the EMR we've identified. You can do coordinated research with feedback loops between policy, treatment guideline, development, and treatment centers. Thank you very much.
Thank you very much. All right, thank you so very much. So a very important announcement for those of us who stayed here. So all of us have to check out, so please do go and check out. Some of us are traveling tonight or this evening. For the rest who will travel tomorrow, kindly see the secretariat staff outside. So we all need to check out of this facility, please. And it's 11 a.m. I beg you. The money will go away. So very important. So all of us have to check out, but those who have to travel tomorrow, kindly see the staff outside. All right. Right, so now we're moving on. Before the health break, we will take the panel discussion for this sub-theme, which Professor Joel Iyani has already led as a discussion. To moderate that session for us, we have Professor Lorna Reyna, who will come and introduce her panel, and then they will do the panel discussion. Then we'll take a health break, and then we come out and discuss all the issues. And then we go home. Yes, I'm itching to go home.
Thank you very much, Lawrence. So we're coming to our panel discussion on sub-theme 4, leveraging data, technology, research and innovation for evidence, importantly, evidence-based, patient-centered and palliative care. Thank you very much, Joel, for your insightful presentation, which I suppose there was quite a picture of a bit of gloom, but hopefully the panelists will be able to illuminate us so that there'll be more light on the issue of data, which is very important for us. So for our panelists, we're going to have representative from Ministry of Health, RSIM. When they come, before they start talking, they'll introduce themselves. Could the representative from MOH, RSIM, thank you. Then we have a digital health expert from GHIMS. Who's the digital health expert? From GIMS, digital health expert from GIMS. We have a representative from Ghana Health Service, PPME, CHIMS. We have Sweden Ghana Medical Center, Dr. Idusa. We have Komfanochi Teaching Hospital, Dr. Ernest Osebon. Then we have CCAN representative. Do we have a CCAN representative? And we don't have our health expert, digital health expert, very important. As has been stressed in the previous presentation and the previous panel discussion, when the representative from the Imam, the chief Imam, also stressed that they need data. So based on this, we'll launch into the discussion. Okay, and hopefully we'll get some contributions from those of you in the audience as well. Thank you very much. Okay, so we'll start with Ministry of Health, RSIM. Very importantly, the role of the Ministry of Health, obviously overarching role with regards to policy, planning, etc., and implementation. And we know data is crucial for this, yes. So what is the Ministry of Health putting in place so that we can ensure that we get credible evidence for national data in Ghana? Thank you.
Okay. Good morning. My name is Ado Simpson. I'm a Deputy Director from the Research, Statistics and Information Management Directorate. So from morning since I entered, the discussion has been on data, and I really appreciate the discussion and the call for this forum, because this is also deepening our effort towards generating evidence for policy reforms within the health sector. And let me say that we at the RSIM, we are the ones responsible for ensuring that evidence or data is generated for policy and also to help in terms of health interventions and reform. And we have been working on a lot of interventions. Last year, we were able to launch what we call the National Health Database. And what we're looking at is to actually, we've identified that one of the things that is actually making, in terms of data, is making in terms of reporting difficulties, that we have a lot of silo systems or a lot of fragmented systems within the health sector. And so we're looking at harmonizing all these platforms into what you call a repository that will make it very easy accessible. And at the end of the day, we can actually have a holistic view when it comes to data. And today, as we are having this forum, one of the things I know it has been coming up is LEMS Games. And it's very good that we're having this discussion, because we know that when it comes to cancer registry, actually, it's not part, let me make it clear, it is not part of EMRs. And the good thing is that as now we have a new king on the block, that is games. I think it's good that we are having this discussion, because now we can begin to have, further discussion, as Dr. Siedu mentioned, that this is not a 9-day wonder. So means that there's room for us to make some discussion on that, so that cancer registry data can actually be looked at and be integrated into it, because there's possibility to be integrated, because ideally, if we are looking at the roadmap for implementation now, they are at the deployment stage. There are a lot of tweaking on the platform to ensure that it's able to, handle most of the let's say, the service delivery or most of our indicators that we actually report on. And therefore, as we know, per practice and where I say that cancer registries happen not to be a major component when it comes to EMR. We can ask Prof's presentation, we could see that when it comes to case identification, yes, you can actually get it. When it comes to detail, you can't have it. And therefore, this forum actually is one of the things that we can use, and we should not end it from here. We should continue doing deliberation, have more discussion with the ministry as well as the company that is actually deploying the solution, that's Axiom, so that some of this information or the cancer registry aspects can be integrated into the platform for us to have a holistic view. And also, as we are also working on the national health database that I mentioned, which I think if we look at the IMAM, they need data. So we need to be able to now be talking about health information exchange, which has been one of our things we're working on, to make sure that we are able to harmonize and also have common understanding when it comes to data. Because sometimes, as you mentioned, you can have data that whenever there's emergency, then it's like something has to be done. Then we begin to gather what we have. But if we're able to harmonize them and have them on a common platform, just as we mentioned, the national health data, it means that when it comes to extraction, when it comes to analysis, we have one point that we can all be able to focus and get what we need at a particular time to take decision. So with the ministry so far, we've been working on the national health database, and then also we are looking at the new king on the block, that is the games. And I'm believing that right from the discussion from morning up to now, since we've been hammering on data and data and data, will be actually be champion that from here, and also begin to look at what is in for everybody to actually, when it comes to health indicators, so that we can all have the adequate information we need in terms of policy, in terms of intervention, in terms of programs, so that we can improve the health sector in a whole. Thank you.
Thank you very much. Okay, so now we also have a representative from the Ghana Health Service, PPME, CHIMS. Yes. Could you introduce yourself and then tell us how the CHIMS is going to feed into the large picture of the GIMS or the national database and the population registry? Thank you.
Okay, thank you very much. So my name is Dr. Salamatu Atanantokma. I'm Deputy Director, Policy Planning, Monitoring and Evaluation. And CHIM is Center for Health Information Management, which sits in the PPMED of the Ghana Health Service. And CHIM is responsible for the system management of DIMS, that is the District Health Information Management System that was mentioned earlier on. And what we do is to ensure that we have a system that is robust enough to be able to ensure that aggregate data for now, to a large extent, the DIMS 2 takes care of aggregate data, even though we now have the e-tracker as well that looks at some transactional data from the community level as well. So in terms of ensuring that we key into what the Ministry of Health's goal is in integration, for instance, I think that what has been a big challenge, especially for a very long time, has been the integration between the electronic medical records and the DIMS2 system. And that was the LIMS and now the GIMS. So one of the things we are working on keenly now is to ensure that even at these initial stages, there are a lot of engagements going on to ensure that the integration between GIMS and DIMS is done from the from the word go, so that we ensure that whatever data that is being collected at the facility level when it comes to electronic medical records is directly linked to the DIMS. In the past, what we're doing was that after electronic medical records are entered, there's a way of reporting, generating the reports which are now entered into the DIMS. And of course, that creates another challenge of data quality issues along the line as well. In terms of being able to ensure that we have data right from the community level, for now, to a large extent, what aspect of DIMS. And what this can be used for to a large extent is to be able to take screening data from the community level. So you can enter data directly from the community level that we can be able to ensure that that is also put together in the DIMS2 system. Talking about the cancer registry, again, the cancer registry is a different system, just mainly like the DIMS2 system. And I think what we are advocating for, again, in Ghana Health Service is the fact that if the health information exchange system is developed, then we know that there's seamless transfer of data between all these systems so that we are able to triangulate information that we have to ensure that decision making is at the best, or we have enough information to be able to take decisions. Presently, like Prof said earlier on, when it comes to DIMS2 data, the ICD DIMS2 records data in ICD-11. And then we have games in ICD-10. And then the other issue is that with NHIA, it's also in ICD-10. And that is actually the little bottleneck we have, because it is because of reimbursement issues. It's easier for the EMRs to use the ICD-10 so that that reimbursement is seamless. But when it's being transferred into DIMS2, then it has to be put in ICD-11, and to a large extent that also creates a lot of challenges when it comes to cause of death certification and eventually the issue of data quality and all that. That engagement as well is being put together by the Ministry of Health to ensure that if NHIA can migrate to ICD-11, then it means that everything goes as it should to a large extent. And with Ghana Health Service as well, we are working on the interoperability issue, because apart from just the electronic medical records not being integrated into the DIMS, we have issues around HRIMS, which is the Health Information Management System, that we have to integrate into the DIMS system as well. So human resource issues from the community level up onto the regional or the national level can all be integrated in one. And again, even with the management system for our logistics as well, is also a different system that has to be integrated. So I think that above all, there's a lot of issues about interoperability that we are working keenly on, and also being able to work on the governance system when it comes to introduction of health information management system, because we have all these systems now that we are looking at interoperability, which is expensive. But moving on from now, when other systems are being introduced, there should be a system to be able to say that these are the standards that you have to follow to ensure that you get the system into place, so that we do not have these issues about interoperability. So that's what we are doing now.
Thank you very much, Salamatu. Yes, a lot of issues that would need people to sit at the table and see. Maybe the DIMS might need to be, looked at as well to make things, interoperable. Not maybe the other way around, us taking ICD-11. It could be a different. Okay, all right. So I think maybe before we go to the private sector, maybe we'll get from Konvanochi Teaching Hospital. You've also been part of the CCAN, City Cancer Registry, and you have your own hospital-based registry as well. Can you tell us some of what you've learned, the best lessons you've learned that maybe you'd be able to advise when it comes to, now that we've moved to the GIMS, based on problems you face with the limbs and how we can approach to make sure we have a better, user-friendly data system for Ghana. Thank you.
Thank you, Prof.
better late than nothing, than never. I was telling my colleague Joel that he sounded very concerning, and sometimes I feel he's frustrated, rightly so. But I tell myself some of the things that we need to do when it comes to cancer registry is not too much for even institutions, but we need commitment and policy direction. And I keep saying this. Kumasi started with a a department-based registry in 2004. Now in 2008, it expanded into a hospital-based cancer registry, courtesy expansion of the pathology services. Now in 2012, we were able to escalate to a population-based cancer registry using the 2010 housing and population census for Ghana. So what was happening? Our data extractors have an extraction sheet that Dr. Yanni showed. So at this point, we included laboratory services, private ones, public ones, Ghana Health Service institutions, BCLR Hospital, SDA Hospital, Confanachi Hospital, and then the birth and death registry. So that was the basis of the population cancer registry. And then we had liaised with the Ghana Statistics, so they defined the Kumasi metropolitan area. So it's the Kumasi Metro Population Cancer-Based Registry until 2021. Now Confanachi migrated onto the LIMS in the last quarter of 2018. So 2019, 2020, 2021, we had challenges with our data collection. Because like my colleague said, the LIMS has not been structured in a friendly way for you to capture certain details that you want. And the programmers felt that the institutional IT management could deal with that. And they tell you, look, you have done your contract, collected your money. I am not to do this. Whether the system was a closed source or open source, we don't even know. Of course, we know some developers will not allow you to, fidget with their system. So suddenly in 1 month, data collectors came around with 2,500 new cases and said, no, there's something wrong somewhere. We are seeing 850 to 1,200 new cases a year. So suddenly we realized something was not right. So that is where data collection has stalled. Thankfully, we had a staff of 4, and then 3 had Jakpa, left 1. And the 1 is being used at the R&D department, and they will hardly release her even to collect data. Come CCAN, we've been given a furnished office and a conference room at the KMA. Computers, everything are there. But because of the problem we've had, we approached the IT team. We want an interface or an adjustment that can enable us to collect the data. And they tell that the data, the program is not ours. We can't do it. And the other people says, we're not told in the beginning to do this. So now we are stuck. I think we have a very big opportunity with the incoming gems. We had an opportunity to sit with the programmers last week. It looks a bit friendly, user-friendly than the LIMS. But then we are trying to tell them exactly what to do so that it can be friendly when it comes to the data for cancer. We think we should get to a point where data can be exported. No more going around with data extraction sheets. But this, we need a hospital management. My friend was talking about organogram. We need that one. We need the hospital IT team. We need the data collectors. We need the clinicians to tell us what information they need to be put in there so that it will be like what is done elsewhere. Now, when these groups sit down, then clinicians will tell what they want based on what pertains outside and quality data. The programmers after discussion, we'll know how to bring it in. The local IT team will also be supported because when they have left, they have to take over. And then the data extractors will also be there. Now, if you don't do that, we have this opportunity. We'll come back after a few years and talk about this thing again. So we spoke to them and they wanted us to give all the feedback. They say a committee should be started. We set it up. We've given all the input, but then they're going to sit with the other teams. I think we need to sit in a round table. They get the data, they do all the necessary adjustments, and then at a go, you can export data. If you don't do that now, we have challenges. So that was my comment for now. The other thing is, if there's no organogram, you go to an institution and they think that you have had a grant to do your research and you are coming to take the data. So you go and you are not allowed access to any data. It's a problem. So again, policy direction from the top to, people down there, that the data is not for anybody, it's for everybody. And then the way we handle the data too is a problem. Somebody comes and says, I'm attending a conference, I need data on cervical cancer. And the person who is there thinks, now what you know, data, it becomes a hassle. Sometimes we hear stories in the background about how they get the data, but this is just rumors. So we need to know exactly who owns the data and how it should be handled. If I'm a surgeon or a pathologist, I'm part of the MDT. I contribute to the data. So if I want access to the data, I think I should have it. But then the hospital should have a clear policy how data can be given out. Otherwise, sometimes people take some of the data and the way they go and present it somewhere, it gives cause for alarm. So all these things are issues. And when there's an organogram, I think we know exactly what to do. So there's an opportunity for us with the inception of the games. We need to settle this right from the word go. And then data can just be exported. Now we are talking about ICD-10. There's an O. I think that one deals with the O. So now we need to sort that one out. I don't know how you guys are going to do that. I'm sure you can do it. So we are very hopeful that we started right from the word go. This is a very nice opportunity for us.
Thank you very much. That there's hope, yes, for a brighter future with regards to quality data. So we'd like to hear from the private sector, Sweden-Ghana Medical Center. Dr. Edosa, you do collect data. How do you collect your data, and how do you, does it go to the national level, or what do you think you'll do differently now? Thank you. What has to be done?
Yeah, thank you, Prof. Yes, within Ghana Medical Center collects data. Our data goes to the Kolebu, right? Accra registry. So it's at Kolebu, and you have IT specialists who come in and collect the data from us. I was listening to the systems that are running on the background. We have our own system, which is HOIS's electronic medical records. So when I listened to that, I said it would be very interesting and would be, I think, best that you can have one system which works for all hospitals in Ghana. That way, everything is linked. That way, you don't need to come in and extract. I mean, you can go in and get a person's medical records straight off from that place. I don't know how far that, whether it's even a plan. The other thing is, we're talking about data. I know Ghana has a Data Act, which Data Protection Act, that's right. I don't know whether there are any representatives here. Sometimes it's very difficult to understand. I mean, who the data belongs, what can you share, what can't you share. There's that doctor, patient, private, So when people come and say, we want this data, are you related to a medical institution? Can you share such data? So there are those nuances and difficulties which we don't understand sometimes, which would be good if it could be clarified.
Thank you very much. Yes. Now, Joel, based on all that we've sort of heard from Ministry of Health, Chim's, Komfanochi's experience, and what you presented. Yes. Are there, what would you suggest as advice going forward for Ministry of Health, which I suppose will be the overarching, where everything will be situated, I presume, unless obviously it's going to be situated, as maybe you suggested, maybe in the teaching hospitals. What would you suggest in terms of implementation, thank you, of our National Cancer Registry?
Yeah, so first of all, let me thank Dr. Edusa for the magnanimity in data collection. So this attests to what I presented, that when we wanted to produce figures, we went to Sweden, Ghana, and they were gracious enough to give us their data, which we included in ours, because they are in the jurisdiction where we calculate the figures. So we are very grateful. But let me also add that by procedure, the data is anonymized. Yes, so you cannot identify the patients. Okay, so they are protected. But I understand what you are saying. At the time that we did these things, the Data Protection Act was yet to go through Parliament. So it means we have to modernize these systems. And in Accra, on our own, we have, Naomi is here, we have a data release form, yes. And we have some guidelines. We have a technical committee that decides whether people's requests are vetted to determine whether we need to give it to them or not. But you see, it means this is at a micro level. It has to be something that everybody agrees upon at the national level. Oh, I've always been hopeful. I've always been hopeful because I think we have the personnel, we have the knowledge. It's just a matter of galvanizing people into action. So I'm confident that once we agree to pursue a certain direction and the will is there, I think we can do it. We need a specific, you see, this meeting is good, but it's very broad. I think we should have a specific meeting, with all the points that we've enumerated here. We should have a specific meeting on a registry. We bring all the stakeholders. And I think that people are knowledgeable enough because they've practiced it. It's not something we just read in books, we've practiced it. They will be able to bring out all the issues. Then we have a direction. We may have a national coordinating office to which all the teaching hospitals report to. But that's just a suggestion. Yeah, but that is what I have in mind. So Korle Bu will report there, all the other hospitals report there, so that we can put the figures together and have national values. Yeah. Thank you.
Yes, I want to add to what Joel just said. I mean, even in America, they don't have one cancer registry. They have it in certain states, but then they do aggregate it at a point. So it's very difficult trying to get one point. I think in Ghana, we have about 3 points, like one in the northern sector, maybe one in the middle belt, and one in the coastal region. It should be enough. If we're able to develop a better electronic system, I mean, data will just have to be exported from these centers, and then there will be the national. It's very difficult to say we want just one center, but once these centers have proper registry, it's a matter of just exporting data and some aggregating and getting the national figure, which would be good for planning purposes and other things. I was wondering yesterday when we were talking about this Ghana medical care, like somebody went to a very rich man and asked whether he could take care of, help him pay the school fees of her children. And he said he'll come tomorrow. The next morning, he opened his door, and there was a queue of many children. And the man said, were there that many? I didn't know. If there are that many, then I'm sorry. I thought there were a couple, maybe just one. So with all this policy that we're intending to embark on, if we don't get the numbers right, we get to the middle and say, we didn't know there were this many people, and we think the funding is not enough. So we should start it right. I think this cancer registry should be speeded up right in this beginning, because before the medical doesn't start. Otherwise, we get into the middle. And the other thing that I wanted to caution is about the tariffs that the institution wants and what the scheme wants to pay. Because on paper, breast cancer and cervical cancer are supposed to be taken care of. Yes, but the tariffs, for instance, that the institutions want for scan, the CT scan, is much less than what the institution will want to, take for. So for that matter, patient will have to pay out of pocket. So some of these issues need to be, resolved before we start. And the numbers we have to get right through the cancer registry.
Thank you very much. Do we have time for just one or two questions? Afterwards, okay. Because I can see, when I was looking at the data that Joel was presenting, pediatric cancers didn't really feature. Okay, all right. And I think it's a good opportunity for us to really get data from the, from the community level to improve on the DIMS data, to get that so that we can get more credible data for the whole country. But I think there's a lot to talk about. And as you suggested, a specific meeting, for data collection. It won't only affect cancer data, obviously. It will be a systems approach, so it would affect all health system data in Ghana, which will be very important. And having the relevant stakeholders all at the table, so that we get the input. And I'm glad that we've got at least GIMS seems to be a bit more user-friendly, as someone has stated, and hopefully you're open to input now, yes, before it's rolled out nationally and the rest. So I think there's a lot to discuss and to,
Yes.
So thank you very much.
All right.
I think.
Yeah. Thank you so very much, Prof, and your panelists. Like we said in the afternoon, we'll reconvene. We'll reconvene, and you have all the discussion. So please take note. My first question will be, so the EMRS data on limbs, where is it? Will it be put back on GIMS? Because you still need your baseline. For any student of implementation science, implementation research, what a fantastic demonstration of implementation outcomes, appropriateness, adaptability, all the issues there. We designed this. I was dizzy when my colleague Salah was speaking. DIMS 2, RIMS, SIM. I'm dizzy. And you have all these theories, conceptualizations, they don't talk to each other, and it's becoming more expensive. Oh, this is fantastic implementation research paper, right? So somebody should take it up. I'm sure you'll get a PhD out of it. They will even make you a professor out of it. Now, we've all ended our break. Let me make a last announcement that please, if you need to check out, please go and check out. You don't need to incur extra costs. So do check out immediately. And if you are traveling tomorrow, please see the secretariat staff outside, and they'll sort you out. So thank you very much. We'll reconvene in 25 minutes to be able to have an extensive discussion. Please note that we will do all our assignments on the paper. We are already 40 minutes behind. And then we reserve lunch for last, so that after lunch we can all depart, okay? So please, when you reconvene, let's straightforward, we look at the discussions. Thankfully, We've sort of done group 6 discussion on strengthening cancer data management, but we'll also pick a few of your questions on that after the health break. So please enjoy your coffee. Oh, I still have the... Please, we still have the phone. So if you've lost your phone,
the open photo crowd.
The beer photos are. Okay. Here we go. The coffee is working. Heart rates up. People are all over the place and excited. But let's reconvene, shall we? Let's give ourselves a minute to reconvene and start. You'll notice you have a sheet of paper with a QR code on it. That's the conference evaluation on your table. 2025 National Cancer Forum evaluation. So kindly scan. Nowadays, even if you want to put away your phone, you can't. Everything is scanned. So please scan the QR codes on your tables. That's a conference evaluation form, please. Shall we take our seats respectfully and start? Okay, thank you very much. So we shall take our seats and start with Chairman's permission. Like I said, kindly scan the QR code on your tables for the evaluation. Now, we'll be looking at two major issues: strengthening oncology centers, human resource and supply chain, and then palliative care, expanding home-based care and community-level integration. We did touch a lot of discussion on the strengthening cancer data management, so along the line, if we still have questions on that and there's time, we'll take that. But to assist us to do that, we'd like to invite, of course, as we did yesterday, our chairman, Senior Dr. A.B., to please come up. And joining him will be Professor Bowen and my president, Madam President, Dr. Hannah Aite. Then we'll have Dr. Abna Furiwa Sapon and Dr. Mrs. B.C. Adewale Asani. Please, if you could join us up here, we'll take a few opening remarks from each of you, and then we'll give the platform to the participants to discuss the issues one after the other. So let's give them a hand of applause. Let's let the coffee work and the carbohydrates, eating healthy. Welcome. The lady say, so, hey, gender bias. Okay. Senior, well, bro. Just agree. Everything they say yes, yes. All right. So I'll hand over to Chair. I think we will start from the end. You introduce yourself, your organization, and your main focus for the discussion, so that when the questions come, we know we are firing at you. All right. Thank you very much. I think we can leave it as it is. They'll block them. Okay.
And I'm from the Ghana Palliative Care Association. I'm actually here to respond to questions on the home-based care and then community integration of palliative care. Thank you.
Thank you. I'm Dr. Hannah Aite, and I'm an oncologist at the National Radiotherapy, Oncology and Nuclear Medicine Center, Korle Bu.
I'm Professor Antoinette Bediako, and I'm a surgeon at the Korle Bu Teaching Hospital and associate professor at the University of Ghana Medical School.
I'm Dr. Abna Furiwa Sapon. I'm a family physician and a palliative medicine physician, I work at the Kolebu Teaching Hospital. I'm here on behalf of Ghana Palliative Care Association and Society of Family Physicians of Ghana.
I'm the luckiest male here. The Bible says, blessed are you among women. So I feel blessed. So we'll start with palliative.
Thank you very much, sir. I'm not sure if I should stand or I can sit. Okay.
You can sit. So
Thank you. So palliative care is fast catching up, and I think yesterday we established that palliative care should be started right at diagnosis and then carry through even after the death of a patient, because the family also receives some sort of support in palliative care. And I think as we gather here, I think we should all give credence to Ghanaians who are suffering from serious life-limiting illnesses. They are not just patients and caregivers. They are our family, our friends, and our communities. And so for palliative care, I'm excited that we get to talk about home-based and community-based care and how we can integrate it into our care and provide care for patients in the comfort of their homes and their communities. So I'll start with my first question. I'd like to know what the challenges or barriers to the provision of palliative care is currently in Ghana, especially in the rural areas. I don't know if Dr. Dewale can take that.
We'll throw it to the general participants, and then later we can come to the panelists to do that. So there's a question for us to look at what, in your experience, are the barriers in Ghana to the successfully undertaking palliative care.
Yes, that's what So we can start by throwing it out to members of the audience. Yes, I think there's someone at the back. I'll repeat the question. Barriers to the provision of palliative care in Ghana, especially in the rural areas.
Hello?
Yes, thank you very much for the question. So the barriers mainly are lack of pain management options, not just the medications, lack of personnel trained, especially for home-based care. You agree with me that home care and institutional care are two very different things. And so, in as much as we are experts in institutional care, in going to the houses, we need to also groom ourselves to be able to deliver the care as expected. So we lack the expertise and the trained personnel to be able to do that. And then currently there is no particular stand-alone policy and strategy for the practice of palliative care. These are the three main problems.
Okay, thank you very much. I think we have another hand up in front. Actually, there are more hands up.
Okay, so thank you very much. So I think to pick up from where she landed, there's no clear policy document or implementation guideline when it comes to palliative care. And also there's a gap when it comes to integration into routine health care. Especially if you look at palliative care, a lot of it should be done in the community level with our community health officers. Recently, with the review of the CHIPS implementation guideline, there's a bit of palliative care that was put into that document, and that we should be able to take leverage on that to ensure that as we go into dissemination and also capacity building at the lower level, there's a lot of emphasis that is put on that.
so that it is integrated into routine practice at the community level or at the CHIPS level, and also into routine reporting. And I think to a large extent, it will go a long way to help. And again, when she talks about morphine, I think it's a critical discussion that has to be looked at. Who will prescribe morphine at the community level? Who, of course, if you look at our health service system, even though probably morphine may not be prescribed at the CHIPS, we have the physician assistants at the health center level, and maybe we should be looking at that as well to see if the physician assistant. But again, it goes into the prescription levels as well. So I think that this is a whole discussion that has to be this, because those are some of the gaps that we have there.
Thank you. A whole policy on implementation, prescription, care delivery.
Okay, thank you. So I'm Dr. Vivian Painter. I'm a consultant pediatric hematologist oncologist. So in terms of palliative care, I think that first is the need for us to create more awareness about it. Because immediately you talk about palliative care, people think about end of life. But palliative care goes beyond end of life. And so if we don't bring that out, possibly through using our health training institutes, so that right from that point, we are able to incorporate palliative care into our schedule. If we don't train our health professionals to know that palliative care starts from diagnosis, then it will be a big problem. And then also having adequate resources. If we talk about home-based care, how are they going to the homes?
Exactly.
That is a big problem. So if we don't have any resources that are added on, then that will be a problem. So funding comes in, and then all the other medications. So as a doctor also said, who is going to prescribe the morphine? Are we going to let the community health nurses prescribe at the CHIPS compound? Or we will let someone at a higher level, possibly at the district or at the regional level, prescribe, they get the medication, and the one who is down at the CHIPS compound oversee to them taking those medications. So they are things that has to be clearly written out as guidelines so that people can follow it. Otherwise, it will be very difficult for us to implement palliative care right down to the communities.
Thank you. Very well spoken. I think that it should be integrated in all levels of healthcare training. So every healthcare provider should have some basic knowledge of palliative care.
Okay. Thank you. Good afternoon. I'm Oswald with the Ghana Coalition of NGOs in Health. Talking about the challenges or barriers to palliative care, I have tabled some for our discussion. That's limited access to specialized facility and experts. Here are we, even considering the cancer registry. The one that I know is in Kumasi, established in 2012, and that of Accra. But then we have even teaching hospitals in Tamale, Cape Coast, Ho. What are we doing? But then looking at how it's skewed towards Accra and Kumasi, I see it to be a challenge. One also will be inadequate funding and logistics. Lack of public knowledge about palliative care. The public perception with palliative care is like the terminal, that's how people will see Kofi, the terminal end. It's like a process within the death and dying. Once someone is referred to the palliative care, all intervention is like we are preparing you for a dignified death or something. That's the perception within the community. So I think more education needs to go there. And one also thing that I think we should also look at, the whole cancer care, I would say is more biased to the clinical interventions. But then most of the things that we can also harvest from the community, the CSOs, with regards to a preventive component, the promotion component. This year, last month, we introduced HPV vaccine. We mobilized our girls between 9 to 14 to get vaccinated against, cervical cancer, liver cancer, Hep B, birth dose. These are the things that we are also trying to also mobilize our community. So it's not only the clinical intervention. I was expecting at least to see at least a component or a representative from the community who would also speak for the promotive component of the cancer care, not only when we have been diagnosed or someone has been diagnosed, then the treatment starts. But then there is a say that prevention is always better than cure. So in as much as we are looking at how we would treat and make people survive after having cancer, let us also look at the preventive component as well. Thank you.
Thank you very much.
I know, right? My name is Na Adoko Aite. So really, a lot of the things I wanted to say have been said. But I just wanted to say that I've been doing this oncology thing for a while. And maybe it was only until 2017, 2018 that I actually had an interaction with palliative care. Throughout my training as a medical student, palliative care really didn't feature. And so I feel like it's too much to expect people who trained, 30 years ago to suddenly understand what palliative care is. You know the barriers and the hesitation around morphine, for example. You would prescribe morphine for somebody, and somebody at the, CHIPS compound healthcare center will encourage the person not to take morphine, for example. So it's a far-reaching problem. And I think that just as we've been able to get breast cancer into the consciousness of people by having multiple discussions and celebrations around it, I think palliative care should make use of the same thing. We need to get our people to understand what palliative care truly is and how significant it can be in the lives of people who have been diagnosed with chronic diseases. When on Monday I saw a patient who is breathless from metastatic breast cancer, and she's insisting that she doesn't want morphine. And her reason is that she'll get side effects from the liver and the kidney. And I'm like, my God, you have difficulty breathing, you are in pain. What you need is to be able to breathe well and to take away your pain. But because of what she's heard, including from nurses who don't know any better, I don't blame them, they don't know any better. So they'll explain to you, that's for morphine, when you take it, you become addicted. And what? Somebody in a wheelchair will get up and go and attack somebody for money to buy morphine. I think we need to do a lot more education if we want palliative care to become part and parcel of our communities.
Thank you very much.
The struggle is real, even for sickle cell pain. The people who do not give morphine are comfortable giving Petidi, and then they'll blame morphine.
Okay, so my name is Brian Mababa Abubakar. So I want to look at the whole cancer care vis-a-vis the health provision structure in Ghana, because the framework is laid out, as was said yesterday, that maybe it's mainly for infectious diseases or clinical cases. But if you look at some of those models, I'm sure we'll be able to leverage on that. Why do I say so? If you take, say, maybe TB screening, it takes place from the community level, that is the CHIPS level, all the way to the hospitals. And sometimes maybe we think screening is just taking blood samples or even looking for lumps. The screening can just be a form, a tool that is even designed to ask certain key questions. And now we should be able to have a score. When you reach this score, even if they cannot examine properly at that level, this person is qualified to be referred to the next level, so that they can do proper examination. Maybe at that level, they may be able to do clinical examination. They may not be able to do a biopsy. Then they also say, okay, then you move to the next year where a biopsy can be done. And then maybe all the way to where maybe even an MRI can be done. So if we use that structure, they will be able to see how we can implement all aspects of this care we are talking about. And of course, we develop indicators for this screening, because for TB, we have our denominators already. We know that, okay, this particular district, this particular sub-district, or this particular facility, you are expected to diagnose or screen this particular number a year. And out of the screen, we are expecting, maybe by modeling, this number to qualify for testing. And then out of that number, we expect this percentage to be. So these are your benchmarks that we work on. I will be able to assess the system and appraise the way we work towards that. And then we can set the goals and move along. So we need to have some of these key indicators that we can be using to monitor how we perform. And I think Auntie Beatrice mentioned putting the cancer patients on leave. I was saying that, well, sometimes the leave can be once every 6 months or even more. That time the patient might have died. So why don't we rather use, again, a model that is used for TB patients, like patient enablers. So we're able to have a fund when you come for review. You are given something as your lorry fare back or for your hot meal for the day. Then you go. So I think that way it can be more sustainable than to put it on leave. Because sometimes the leave can be, I don't know which other word it can be. So maybe.
Thank you very much. Okay. We have some comments online, but we do not have a palliative care competency framework that informs the formal education of health professionals. I think that's what Doc was saying. And definition of scope of practice of the various cadres at the various levels. Okay, that was from Edwin Addo, Opariloko. And the next is from Tampuri on the cancer registry. We'll get back to that. I think there are a few comments. I don't know if you want to take them or you want to.
Yes. Okay. After that, we'll zoom into the home-based care regulations. Okay. Yes.
Thank you. My name is Gloria Youngson from Cancer Connect. So I'll be very quick. I was very excited when palliative care was initiated in Ghana, and I'm very happy that it still continues. But I guess there are a few gaps. I think I'll mention just two that we should consider. We should consider integrating our culture and our spirituality into palliative care, as in Ghana, not as has been thought by other countries. I'll just quickly share a patient's experience. Very recently, diagnosed late with liver cancer, eventually was referred to palliative care at a very late stage after all the diagnostics, no treatment, and then has a team of 4 palliative care professionals go home and tell the family, didn't even meet the patient initially, tell the family that basically he's at the end of life, so you need to put your house together. It was very blunt. There was no cultural sensitivity, nothing, as they explained to me. But the point here is we need to, again, start earlier enough, integrate culture into it as spirituality. If we could actually even include a person from the chief imam was here representing, if we could include that, I believe they could also play their role. The Christian Council was here as well. Even do home visits from the church or from the mosque and stuff on behalf of the palliative care team as well. I think there's a lot that we can do together to push this forward. Thank you.
Thank you. I'm glad you brought this up because it moves me to the issue of regulation of who provides the home-based care, what qualification they have. For most trained palliative care people, how to sensitively and culturally, or to communicate in a culturally accepted manner is trained, or is given. But now you have all sorts of people providing what we call home-based care or home-based nursing. I think with us here, what are the regulations for home-based care? Who can say that they are allowed to go home and provide care? To what extent can they provide care? What can be done at home and what cannot be done? Are there any regulations in place for home-based care? Because once this becomes accepted, there should be some sort of monitoring. And a lot of cancer patients may be at home and not be able to go to the hospital, and we'll have to rely on nurses and other people to take care of them at home. But the question is, are there any regulations? Who do we allow to go home and see these patients?
A quick one. It's not on this question, but a comment on the home-based palliative care. I think we must all agree that as health professionals, we are not communicating well with our patients and with the relatives. Now, a patient comes to your clinic who cannot receive any active oncology treatment. For that matter, you ask the patient, is there any hospital close to where you live? He says yes. Then you write a letter to that doctor that this is a patient who is at this stage, we are only maybe controlling pain. And for that matter, I'm sending the patient, and when the medication is finished, he will come for a refill. If there are any challenges, please let me know. And then you don't even tell the patient, you don't tell the relative, you say, take this letter to this hospital. And they are at a loss. I think you can counsel them well. Our pre-diagnostic counseling, our pre-treatment counseling, our follow-up counseling have not been good enough. We must accept it. And we need to, make it better. Now, once you communicate to the patient and the relatives, this part of the psychosocial support, psychologically, emotionally, spiritually, well, the pastors could come in sometimes. But let them know that this is where we are. So there's no point traveling 400 kilometers every time to come and collect pain medication. I'm asking you to go to this hospital, which is closer to home. I'm going to call the doctor. I'll have a discussion. Often the doctor there is not comfortable that a patient is so sick, and then you taking the patient to him to manage. He's not a cancer doctor. So they are not comfortable. But once you speak to them that this is what we are doing, this is what we are supposed to do, if you have challenges, call me. They are very comfortable, and they can take it from there. So we need to communicate well, and we need to make sure where the patient is ending up, we're giving the person some kind of confidence to manage the case. Otherwise, in our culture, somebody comes home and says, hey, if you move to a hospital, it's like the relatives, you are being implicated that you are neglecting. But once they know what the doctor has told them, at least they can explain why the patient is at home. So we must communicate well. Thank you.
Thank you. To add on, there are patients who are sometimes even referred and informed that when you get there, you'll be told what is wrong with you. And this is somebody who has seen the patient for months, for weeks, and says that when you get to that new doctor who does not know you and is relying on secondary data, when you get to that doctor or team, they will tell you what is going on. We should communicate better.
Yeah, thank you. My name is Ayire Adongo from World Child Cancer. I think policies, strategies on home-based care, I haven't seen any, even routinely, I mean for general services. It was one Dr. Chandi who was working on something like that, but I don't know how far she has gone. But with regards to palliative care, I'm sure we've just been told we don't have the policy yet. And from the organization I represent, you realize my interest is on the children. But even the general policy is not yet out. But we are making efforts to ensure that the children's palliative care is well integrated. That aside, even for the other services, for instance, primary health care, when you move from the teaching hospitals and you go to the regional hospitals, to the district hospitals, I mean, these services are virtually absent, apart from the recent time that we have done a very good work on building capacity on children's palliative care, and that is even for children's palliative care. But for adult palliative care, these structures are non-existent. So I think we need to look at the step-by-step this thing in building it up to the community level. You also realize that we do not have adequate hospice facilities around that could have done most of these things. the hospice services are virtually inadequate to even talk about. So let's take step by step and see what we can do. In other countries, they have most of these hospice services. So I think we have a lot to do, and then we can zero in on the home-based services. And we also need to build capacity. World Child Cancer has worked with the Ghana College of Physicians and Surgeons, and they are rolling out a post-fellowship program next year on children's palliative care. And then the Ghana College of Nurses and Midwives, they are already training nurses on palliative care to specialize in palliative care. So we need to build capacity, and then we can now zero in on building a very strong home-based service for palliative care. Thank you.
Okay, so actually there is 0 hospice in Ghana. It's 0. And though it's 0, we try to offer some sort of hospice services, home hospice concepts. We try to do inpatient concepts, or maybe consults, to be able to at least give some dignity to our person, but we do not have any facility at all. And on the question, Dr. Sapon, you asked who should practice home-based care, and how is it regulated at the moment? There is no regulation for home-based care. We sort of are playing on the gray spot. There are a lot of home agencies, and they are operating because HEFRES Act is facility-based. But when it moves outside the facility, they can't really touch on them. And everybody is playing on that gray spot and doing whatever they can in their homes. Let me just play the devil's advocate and put it that way. But there is an extreme importance for home-based care that we cannot ignore it and throw them under the bus that this is not a service that there are so many problems. Yes, there are problems, but we can solve them. How do we do that? Can we, together with an agency like HEFRA, plan something, include it in the policy and the strategy that is yet to be launched, and have a body that oversees out of hospital concepts, not just home-based care. People are practicing in vans, they are doing community outreach, they are doing a whole lot of things. Technology is advancing, people want to do something on the app, and it is helpful, we can ride on it, but can we put it in the notes and make sure that something is overseeing it? Then it will be helpful. At the moment, if you enter somebody's home and then something happens, then there will be something happening to you. So everybody is just doing it, but it is not regulated, it is not being superseen, and it is not right. Who should write prescriptions? Of course, prescriptions will go to those who have prescription rights, but there is about 87% of things you can do at home that has nothing to do with prescriptions. So physiotherapists have their own thing they can do. Social services have their own thing they can do. Nurses have their own thing they are licensed to do. And we must strengthen the system for everybody to be able to implement what they're doing in institutions at the appropriate, in an appropriate way in the homes. Like I mentioned earlier, when you get to the house, that's not where you start ordering oxygen. Put them on oxygen, because you have to check availability and how you can continue it. So when you are trained in that capacity, then you'll be able to see through how I do all that. And that is when Edwina was talking about competency framework. How do we find out who should do what? Train them to be able to implement it well. Include family caregivers. We call them informal carers, and let them know what they can do in one way or the other.
Thank you very much, Winifred. I just wanted to maybe ask Amna, and yes, while we are trying to formalize the policy, competency framework, all of that, where do the traditional people come in? For instance, we have the traditional birth attendants, and they have been working, from time immemorial. So what about the people? Because we know we have a human resource problem. If you should ask how many palliative care physicians or so are out there, I'm sure we all know. And our patients are coming from all over the country. How do these people come in, even though there's no policy backing it? Is it something that we could consider? Training some people to actually provide the care right at the source?
Well, the moderator is speaking now. So,
I think
okay, I was going to respond.
you will talk and talk and talk and talk, you won't finish. It looks to me we are mixing three things: palliative care, end-of-life care, and pain control. We are talking about palliative care, but most of the things we are talking about here, like home care, end-of-life care, maybe Ministry of Health should pick this and we develop the whole guidelines on palliative care, end-of-life care, pain control. Because I have a nasty experience. I had my nephew with liver cancer, and we've managed this boy at home for 3 months. He went to hospital one day, then my sister called me. And it was as if this boy was sick, and because of money, I don't want them to go to hospital. So I say, he went to Konfuanochi, and 3 days time he died. Then they come by, his brother said, "How can you?" I'm so okay. So we don't have to mix end-of-life care, pain control, and then palliative care. Because palliative care starts from day one. Day one. And we have multidisciplinary clinics. So palliative care people, you have a space on the MDT that from day one, you pay the patient, and if there are palliative care issues, occupational health, physiotherapy, social, financial issues and other things, all these are part of this whole palliative care issues. And it was born out of cost effectiveness and evidence base. Because there are times that somebody have, end-stage disease, and people are still prescribing expensive medicine. That's how come people sat down and said, let's begin to look at the end stage and manage them at that level. So if we are copying from people who, started this, let's copy well, look at when we have to stop active treatment and manage these patients with supportive care. So please, I think this issue that Ministry of Health to pick it. We will talk and talk and talk out of emotions. Let's look at science, how we can use science to deal with it. So I'm proposing we tackling this from pain control, end of life, and palliative care. Thank you.
Actually, I would say that palliative care is actually the big umbrella.
Yeah.
And so pain management, psychosocial care, end-of-life care, all fall under palliative care. And palliative care depends on the needs of the patient. And so depending on what the needs are at a particular time, the care is met. And that's how come we've moved away from the previous care where curative measures go on, and when that doesn't work, go for palliative care. What we are advocating for is palliative care is starting right at diagnosis, because sometimes even how you communicate a diagnosis to a patient can determine if they will continue with the care or not. And so palliative care may not be needed very significantly at the beginning. It will be needed, but its input may not be much. But you'd realize that as you move along, then depending on what the needs of the patient are, you address it. And so for that patient, speaking to the patient with the liver cancer right at the beginning, letting them know the expectations, what to do at end of life, signs of imminent death, we're all important. And then when you get to the end of life, you provide that hospice care. We've moved away from when we thought palliative care was equal to hospice care. Thank you.
I'm wondering if you leave it to them, they will talk and talk and talk. The message I'm getting, Dr. Bafo is an oncologist. And for him to raise those questions means even there is some learning we all need to do about palliative care. So I'm proposing that maybe we should have a dedicated discussion or a group to go into this into a lot more detail. So we're going to begin to wind up the discussion on palliative care. What I'm getting is that is, yes. All right, so we'll take one here and then colleagues here will wrap up.
Thank you very much for the opportunity. My name is Mary Idrisu from University of Ghana, School of Nursing and Midwifery. So with respect to training of palliative care specialists, we know that if you want to get everybody to go to the Ghana College, it means that you need to get study leave. And then study leave is limited. Meanwhile, we have a lot of people doing home-based palliative care. Currently, we are taking the data, and the intent is to be able to develop a framework for home care services in Ghana. And then we realize that the people who are rendering the home care services are nurses who've completed school and they've not been employed, and they are doing this. And then they share their experiences. Even the concept of the home care is poorly understood. Some people are made to clean louvers. Some people are pounding fufu in homes. They are being maltreated by households. Some people are also made to sleep in a room alone with cremated ashes or bodies. And then they have a lot of psychosocial issues. So I am proposing that in addition to we sponsoring people to go to the Ghana College to be trained as palliative care specialists, can we have models, CPD points, so that we can run in hospitals? I remember some time ago, Ghana Health Service moved around the county to train us in emergency care triaging. Can we have something like that? Because it's a topical issue now, so that we can have a lot of people having the training. We also have other ones on online free, so that people can go on, because if we want to wait for people to go to Ghana College, when are we going to do that? Is the government prepared to pay specialist amounts for such people? All of us can get training so far as we are the clinical area and you get in contact with such people. Thank you for the opportunity once again.
All right, so you are reminding us that there is some urgency to this, but let's also think it through so that we don't create problems for ourselves. Colleagues.
Thank you very much. I think I have some points here, but majority of the points have been raised. But we are wrapping up on this topic, and one important thing is awareness creation, not just among the healthcare professionals, but even the general public. We want to move into community. For us to move into community, community must understand this concept, palliative care. And we always have issues with late referrals. So I'm coming back to the issue of why people think palliative care is end-of-life care. And this is a misconception about the whole palliative care idea. So I think one thing the ministry will have to do is look at how we can incorporate palliative care awareness creation in every aspect of the healthcare system, not just even in cancer care. Everyone needs palliative care. Palliative care is multidisciplinary, so we work with various disciplines, and we're looking at community care. One, community integration. In the community, we have other people we need to involve in palliative care. Community volunteers, herbal medication, what do you call it, attendants, or those who use the herbal medications to treat the patient. Also, the spiritual leaders, the chiefs. Everyone needs to gain some kind of understanding of what palliative care is all about. And we live in a context where we cannot do away with our family caregivers.
we believe in extended family support. So family caregivers, we see them always with these patients. How can we train these family caregivers for them to be able to provide the needed care and support for their relatives whilst supporting these family caregivers themselves? Because palliative care does not only focus on the patient alone, but also the family caregivers. How do we support them? How do we train them? And we've all been talking about policy, which is very important. Without policy, all these things we are discussing here cannot get to where we expect it to get to within the number of years we are looking at. I know the Ghana Palliative Care Association is working on a strategic plan towards improving palliative care from the primary level to the tertiary level, ensuring policy is captured, strategies are put in place, monitoring is also captured. Acceptability is very important. If our people don't accept palliative care, we cannot have it work the way we are expecting it to do. So research needs to be conducted to see where our people are ready, that is the Ghanaian people are ready to accept palliative care within the primary health care level too. But our focus is more on improving upon the palliative care at the primary level. And the last thing I would like to say is that research is very important for us to get this where we need to get it. Thank you very much.
Thank you very much. I just want to add, to reiterate the fact that education of colleagues, of ourselves, apart from acceptance in the community, in addition, for us to understand as healthcare professionals the whole concept of palliative care, the holistic aspect of it. One of my colleagues, palliative care physician, will tell me, even our own colleagues call her the angel of death. Once she gets to the ward, then the angel of death has arrived. So it means that amongst us, we need to really understand it and sort of help the patients as well.
So, Chairman, I think we can move on to the next topic.
We'll move to the next topic. I'm sure you have questions, and since you are clever, you'll find a way to ask the question you wanted to ask, irrespective of the topic. So we'll move on. We have colleagues here.
That's right. So there were a few comments, but they have been largely discussed about the curriculum development, including palliative care. And there was a mention about, you said it's not just about cancers, non-malignant conditions.
How do we mainstream?
So it has to be part of all that we do.
So what I gather is this is a relatively new thing for many of us. We need awareness. We need policies. We need regulation, and we need training. And it's important that we also situate this in our cultural context. Most Ghanaians want to be treated at home, but at the same time, they don't want their relatives to die at home. That's why when somebody dies, they say died at Kolebu. They don't say died at home. So we need to think about all this as well. Thank you very much.
All right, so the next topic, the same panel, we'll look at, eventually we sort of looked at aspects of it, which is about the main treatment of cancers in our oncology centers, how we are strengthening these oncology centers, the workforce or the human resource with the training, and of course, supply chain, procurement issues, access to therapies. So that's what we are looking at. So maybe we can take your comments initially on these, the gaps, the strengths, how we are able to do it, and we'll listen to some opinions from the floor. Please introduce yourself before.
We introduced ourselves already.
Oh, really? And your coffee has some room.
So I'm Antoinette Bediakubowan. I'm a surgeon. So our topic is to discuss the treatment for cancer care. I think treatment for cancer care is multifaceted, but we are focusing on strengthening oncology centers, hoping that oncology centers will do multifaceted things. Focus on strengthening human resource and then the supply chain. In Ghana, even though we have institutions having different modalities of treatment for cancer, in those institutions they may be at different places such that you go to one place to go see the surgeon, go to another place to go see the oncologist, go to another place to go and do the MRI, go to another place to go and do blood work and all that. So in strengthening cancer care, in setting up oncology centers, what really are the barriers in setting up oncology centers that may be at par with other places? And if we talk about challenges in setting up these oncology centers, you should also prefer some solutions to it, and then talk about the resources that we need for these centers. So I think that's what we'll throw to the floor, and that we can have comments from the floor. Maybe this is not as interesting as palliative care.
When someone starts, it heats up, and all of a sudden, there's an avalanche of hands.
So, I said yesterday that for now we have 3 comprehensive cancer treatment centers in Kumasi, Kolebu, in Kumasi and Accra. These are where they are located. Besides that, some aspects of cancer management are done in other facilities. We must accept. But we all accept that cancer is managed by the multidisciplinary team. And some of these hospitals or facilities where some aspect of cancer management take place don't have the full complement of the MDT. So we were suggesting yesterday that they could make use of the telemedicine device to join centers which have the full complement of the MDT and discuss their cases. I think that is one thing we can do to strengthen cancer management. Now, besides that, cancer management shouldn't be interrupted, if I should say. And for me, because I'm a radiation oncologist, I've been saying that, or it is known that about 70% of all cancer patients at a point in time will require radiotherapy. Now we have centers, but there's always interruption in radiotherapy treatment. And the issue is we don't have adequate machines. IAEA says that every 1 million people should have access to 1 radiotherapy machine. Going by that, Ghana should have about 30 radiotherapy machines. But we have how many? We have 5. Kolebu has 2, Sweden Ghana has 1, Konfanaji has 1, 4. So I think we should make a conscious effort. And now that we want to make geographical access, or we want to make patients have access to treatment conveniently, we must never start to put a machine at one center, just 1, 2 or 3, if you can afford. I think, look, if treatment is interrupted, it's like killing a snake. If you don't hit it hard to kill it, it got to bite you with a lot of venom. So there should be no reason a center, for our plant preventive maintenance contract with the Varian, the gentleman always tells us, but how can you run a center with 1 treatment machine? He's angry. He doesn't understand why a machine breaks down, we are calling, we need a part, and say, how can you run? So for him, it's a non-starter. So I'm pleading, if the authorities are listening, the new center that they want to come up in Tamale, Ho, and Cape Coast, they should at least provide them 2 machines, so that when one is broken down, patients are migrated onto the other one. So that we can do to improve the treatment of cancer. Thank you.
and should make them child-friendly. Child-friendly. It's not just adults who need
Can I
radiotherapy.
see some clarification? Are you proposing that we should have dedicated oncology centers, or our existing health facilities should be strengthened to have oncology? Because this is very important to the politician. We need to know.
And for now, if you can't have many centers, the ones that are treating should be able to treat continuously. If they plan to open up
the question, are you proposing that the government should set up dedicated standalone oncology centers, or the existing health facilities should be strengthened to have functioning oncology units that have more than 3 machines?
If you say standalone, does it mean we shouldn't set up new centers?
All right. So, for example, a group has come and say they want to set up a child cancer center.
Yes.
In Chebi.
Yes.
Should we be encouraging that? Or should we say, look, there is Kofodia Specialist Hospital. That center should be part of it? Or do we need both?
I mean,
yes.
Treatment shouldn't be concentrated in one center. If they have the capacity to set a new center at Chebi, my advice will be, please make sure that center is able to treat continuously without interruption. That's what I would say. If there's more capacity, I'll ask them to augment the equipment at the existing centers. If they still have the money, I will encourage them to geographically make the equipments more accessible to patients by establishing new ones at other places. But then if you don't have the capacity or the money to establish entirely new centers, then make sure the existing centers can treat continuously. Now, this is the advice I will give. Thank you.
I would also say that as you set up new centers, think about human resource. We have a lot of new hospitals springing up that they fall on the same human resource to go there to practice. So the same human resources are dividing themselves into 10 and practicing in different new hospitals. So maybe we should think about strengthening what we have at where the human resource is, and then as more people are trained and they get more experience, we say, oh, we've trained this number of people, all of you move here. This number of people, all of you move here. But when you don't have the human resource, it's very difficult to say, go and build new oncology centers when the resource is not there.
So just to add on to what has just been said, yes, human resource is very important, but sustainability is also another important thing. We don't create things that we cannot sustain. Eventually it gets somewhere and we are stuck. So sustainability, I think, is what I'll add to it. How best they can sustain what is there or what they are adding to ensure that it's continuous and it expands beyond just the tertiary, but also move down towards the other gradually. Thank you.
Yeah, I'm Tom Coney, Ghanaian oncologist, Konfanoshi Teaching Hospital. I want to move on with the human resource bit. For these cancer centers, it's not only radiation. We have the chemotherapy component. We have the surgical component. In which case, when we're talking about cancer centers, we should be looking at these 3 areas. Unfortunately, radiation, we cannot move the machines to other areas. But for the chemotherapy aspect, we can train people who are interested in the cancer management of our patient, the nurses. In which case, then the pharmacists will also come in. So in talking about treatment centers, let's have in mind that there are 3 components: the surgical, the chemotherapy, and then the radiation. Thank you.
Let's have some more, yes. Because at the moment, there is some appetite in government to build centers. So we need to make sure that this time around, we advise them properly.
Yes. So my comment really is about workforce and getting them to stay. The the fact that we need cancer centers, that cannot be overemphasized. We need it. I mean, you have people travel for hours to come and sleep in open spaces in Korle Bu just to have radiotherapy. And if it's your family members, you won't like it. Thank God for the facility at pediatrics where adult cancer patients get to go. It's frustrating to see your patients suffer for things like that. But also I want to comment about all the effort that has been put into training of oncologists, nurse oncologists, therapy radiographers, physicists, who are one of the endangered species worldwide. We will spend so much money, so much effort to train them, and then the UK will come and take them. I mean, for the past maybe 5-6 years, my center has suffered such a move of young people, and I cannot blame them. For a long while, we couldn't even identify where their level was on the payment scale. And so if they leave, you can understand why they leave. There's the Ghana College is trying hard to make it attractive for young people to come and do oncology, etc. When they are done and the conditions are not right, they will leave. And channels have been created everywhere, in America, in the UK, in Australia, in South Africa. The young people who've left are making it easier for the rest to follow. So if we are not careful, we will get the people who come and say we want to set up cancer care centers wherever, but there will be nobody to man those areas. So we must, as we think about the various centers, think about human resource. And then the other thing I wanted to comment on is that, yes, it's good to have new centers, but I think that because of our lack of human resource, we must think about the established, for example, teaching hospitals. I can understand that it will be easier to have a comprehensive cancer center at Cape Coast Teaching Hospital, for example, because even though currently they might not have the full complement, majority of the members of the tumor board will be available there, and it's easier to just bring in 1 or 2 people compared to when you set up a new center and you the whole team of people to move. What happened with UGMC is that the doctors and specialists from Korle Bu moved there, and so in the end, yesterday, Josephine was telling me about how they have problems at the surgery because there aren't a lot of lecturers at University of Ghana Medical School for surgery. They've moved on. Everybody wants better conditions of service. We have to think about that as well.
So not just the centers, the human resources, and how to retain them. Now we train them and we ourselves send them to Barbados. Yes.
All right, that's Naomi. I'm an oncology nurse specialist. There is a reference point. We can have, I think just last year there was IAEA and WHO, we published this, policy or guidelines on setting up a cancer center, and most of us were part of it. And what we are saying that let's look within what we have within, because we're having, if we export what is happening outside, it may not work within our setting. Because example is Korle Bu. We have the surgeons up there and all over, and we have the radiation or clinical oncologists at one end. But elsewhere, they have all of them at one side for patients to have, be able to see all those specialists. But let's look within, what we have within, and use it to be able to build our own. And having cancer centers, as my friend said, it's attractive, it's very nice. But just looking at in terms of money, maintenance, it's quite expensive
we are paying over $200,000 a year just for maintenance agreement and so forth. So we should all look at that holistically, so that if we are doing such a thing and sustaining it, we should also think about sustaining it. It's very, very important. Just example, Zambia has this had a center, and for some time now it's not working because in terms of sustenance was an issue. Now they are coming back to come and use as a benchmark to go back because they've installed new machines. So we should look at all that holistically when we are making such a move. Thank you very much.
This is very important. I know, for example, that the Presbyterian Church wants to set up a cancer center. So some of these discussion and some of these guidelines will help. So let's look at some of these. I'm wondering, yes.
Yes, thank you very much. So I just wanted to, add to what my colleagues have just said. You know, with part of the human resource we've been discussing. So in recent times, the Ghana College of Physicians and Surgeons, together with Roche Pharmaceuticals and GMA, have come together to look at how we could improve on the human resource. In Ghana, we are trained as clinical oncologists, radiotherapy and oncology, but we have just a few in pure medical oncology. So, and you know, you don't need, medical oncologists does not necessarily need a radiotherapy center where they are to actually start seeing the patient. So what we are doing is we are training some doctors from Ghana in Kenya. So it's going to be a train-the-trainer program. So they're going to go out and come back, and this is being picked from various regional areas, so that where the facilities are, they have the capability to treat. They'll come train others, and within a short time, as we are training the clinical oncologists, we're also training the medical oncologists to spread out. So our patients can also see them where they are and maybe refer to the radiotherapy centers when they are seen. So those that can be managed by them will be managed. It will also help decentralize the system as well. So that's also another avenue for improving on the human resource. Thank you.
All right, thank you. So, good afternoon. Dr. Chair, good afternoon. I'm Osi Ancha. I'm from Traditional Medicine Practice Council. I remember you said we are so intelligent, we find ways of still bringing our matter in. Human resource.
We guess what you are going to talk about.
Yes, yeah, you get it. So can we think of the traditional medicine practitioners as also part of the human resource in this case? I'd like to say that yes, because whether we like it, yes or no, many people will patronize the practitioners when they have cancer. Now, and yes, the herbal medicines do have some effect on the role of cancer management, not to substitute, but as a complementary. As a matter of fact, there are studies that some herbs actually help potentiate the effect of chemotherapeutic agents or even reduce their side effects. So now, my point here is that we have to manage the communication. As a matter of fact, the people will still go. So how about the other way around of we training the practitioners to identify these conditions and maybe create referral pathways for them? How about really encouraging the people that, well, they should not tell the patients to throw away or stop patronizing the chemotherapy or all the other radiation therapies. But take the complementary therapies as well, but they should continue with that. When we should go this way, that co-management will really help. Dr. Chair, let me end.
So I would say that as we encourage our patients to not to throw away orthodox medicine, you're encouraging them also to go to their traditionalists. I think we also have to educate our traditionalists about telling patients to stay on track. We also have to educate our traditionalists about seeing what they can do something about and what they can do nothing about, and say this one is out of my terrain and go here, and this one, yes, we can do something to potentiate orthodox medicine. I think it's a two-way thing, and for now, what works, we should encourage our patients to go along with what works.
So I think you are saying the same thing. What he's proposing is, because of this, it's important that right from the beginning, traditional healers are part of the conversation, so that they don't go on the television and radio educating people on cancer and providing sometimes not too correct information. So they should be part of the... So your suggestion is a good one. We will ensure that as we move along, traditional healers are part of the conversation. And
Mr. Chair, thank you. So I'm also looking at whether we should cite more cancer centers or expand the ones we have already. I'm saying we should look at the data, look at the burden. That will help us with the citing. And even when we look at the current services that we are providing, and then we look at the numbers that we are seeing vis-a-vis cancer cases, then that will help us, apart from the politics. So that will help us. And then when we look at the burden, that one will even determine the kind of equipment that we need, who we should train, because resources are scarce. We'll be able to prioritize that. Let's give ourselves about 5-10 years, and we will be able to do that. So we can cite it well where the numbers are, not also forgetting about equity. The other one that we can also look at, we are talking about private and public partnership, where government will be able to support individuals to be able to take up some of these challenges. And in terms of citing these centers, in terms of importing the type of equipment that we have, all these can come, even medicines with all others, can come in and support what we want to do going forward. But we should have a plan, the numbers that we are looking at, how many years that we want to go, and that will fashion the way that we do things. Thank you.
Very good. So he's advising that we should work towards making sure that the citing, if there are new centers, they are also informed by evidence and the science, and not by the usual simple administrative political thing, one region, one onco center, one region, one constituency, one cancer center.
I think moving on, the other thing we needed to discuss was supply chain, and when it comes to cancer care. So if we can have some comments on supply chain also.
Okay, thank you very much. I'm not overdosing, this is a different topic, so, and I need to talk about it. So I'm Ayira Dongo from Wiltshire Cancer. With regards to the human resource, I just wanted to add something. I'm happy she added about the medical physicists, but the HR is not only about the modes of treatment, because the MDT is very, very important. You have social workers, like the healthcare play therapists, otherwise called the child life specialists. They are very, very critical. And the Ministry of Health this year has really been very instrumental in helping Wiltshire Cancer through Amgen to get this program for the first time in the continent. We have an MA program which started last year in South Africa, and Ghana is having the first MSc in play therapy, which is supposed to start next year. And this is where the academia is very, very important. We have been
This advert has been approved by the FDA.
So we have been struggling to get the program approved and started next year because we have funding and we are having challenges. So the Ministry of Health, the academia has to be very, very instrumental in this. This is not about advert, this is about sustainability. And it's going to be at the University of Ghana. in collaboration with UHAS. And the other aspects too has to do with government supporting in the training. I'm not sure if there is a clear plan about the capacity building of institutions, because at least I would have expected that every region would have a rollout plan for supporting the capacities of regional hospitals and other places in building their capacity.
Welcome to Ghana.
Yeah, I'm a Ghanaian.
Yes.
World Child Cancer has supported most of the teaching hospitals and other facilities to build their capacity. But that ends it. The government is not supporting in equipping these facilities. We don't see it in budgets. And I think we all have a role to play in making advocating for these institutions to have the requisite equipment for the management. We can't just be talking and not hitting the nail at the right places so that we get the institutions to support them to equip. Because we know the problems. And another example is the NHIA and what is happening about treatment. NHIA taking 4 cancers. Somebody mentioned cervical cancer and breast cancer, and we know the problems. So we just have to let the government know that these things are not working. You go there and children are not benefiting, and they have to still pay out of pocket. So are we deceiving ourselves? So let's call a spade a spade. It's not working. And let's get NHIA to do the right thing and government to really fund so that we get things working. Thank you.
Now we inviting questions on supply chain. We have an opportunity now, so please don't just lament. Come up with concrete recommendations on how we can move forward.
So, once a more you have a better canamon.
So what we're talking about is how do we get the medicines, the other essential supplies that are needed on a sustained, but also what can we do to reduce the cost? As our colleague just said, there are even some childhood cancers that are supposed to be covered by NHIA. The tariffs are so low, sometimes even the medicines are not available because this is not something people stock on a regular basis. How can we improve on this? Yesterday, somebody talked about pooled procurement. So those are the issues we want to discuss. Yes. Roche.
Okay, Dr. Chair.
Roche, then Dr. Ajani.
Chair, there's somebody here.
Yes, please.
All right, thank you very much. So on the supply chain issues, my name is Kafui and I work with CHAI. We had started some work with the Ministry of Health on establishing a coordinated procurement system for oncology medicines. As we speak now, the various facilities procure their own oncology medicines. The volumes are not big enough to be able to negotiate better prices for these medications. So that's fragmented procurement in the space. Suppliers, because of the volumes are not attractive enough, we have fewer suppliers in the system, because if you think about the economics of it and how much you have to spend to be able to even register a product and all of that, it doesn't make sense to be chasing these small volumes. And so we have very fewer suppliers within the system. And there are a couple of other issues in terms of ensuring that these medicines are consistently available. And so there's the need for us to begin to think about pulling all of this, the demand across the treatment centers together, so that we have enough volumes being managed by the Ministry of Health, leading the procurement system, and then facilities then calling for those products based on the negotiated prices that have been established. Thankfully, there's the announcement of the Ghana Medical Trust Fund currently that should be paying for these medicines. We have a pooled procurement system. All that we need to do now is to plug in the Ghana Medical Trust Fund in terms of making the payment to the facilities or to suppliers, whichever models that we want to look at. So essentially, my proposal is that we should move forward the agenda of having a pooled procurement system for these oncology medicines, both for the chemotherapies, the palliative care, supportive care, and all the other things within that space. Thank you.
And this is a web example because it's been done elsewhere already. But Ghana, they're very fraud. Rush was mentioned, so they have more money.
Good afternoon. So I would want to comment on Kafui's points before I make my own point. So the issue with pool procurement in its current status is looking at just raising volumes to reduce pricing. But we know cancer is an expensive space, such that even if you get pharmaceutical companies to give you even 90% discount, the patients who will be able to pay the 10% are very few. And at the end of the day, the manufacturer would have subsidized the government, all right, but they will not be making enough sales. So that would always defeat pool procurement. And if we really want to get an efficient pool procurement, then we need to secure funding for such a program. That's how come, as Kafui said, an initiative like the Mahama Cares will be important. But if we just look at pooling the different drugs together so that we buy in volumes, initially what may happen is you get people interested in saying, oh, okay, I think I'm making some money. Just some few months down the line, they'll realize the stocks they've supplied are still sitting on shelves because patients are not being able to afford them. So if we really want to consider pool procurement as an option, then we should have guaranteed funding for the pool procurement. That's the only way to make it sustainable and more meaningful for pharmaceutical companies. The other bit I wanted to talk about earlier with regards to ensuring that medicines are available. It's interesting that we mentioned 4 childhood cancers, we mentioned breast cancer, but as we are getting from feedback in the room, almost always you tend not to get medicines available. The only one that I'm sure people in the room can testify is Herceptin. The reason why you would always have Herceptin being present was there was an agreed arrangement between government and directly with the manufacturer Roche, where Roche knows our responsibilities under that agreement, what we are supposed to do, and we also have the guarantee from government that once you supply Herceptin, we are going to pay Herceptin. That guarantee forces us to continuously ensure that stocks are regularly available. But where NHI just puts medicine on the medicine list with no binding agreement and leave for people who think they have their product available, then issues of non-availability keeps happening, then patients will be forced to pay outside. So if we really want to guarantee continuous supply chain, then government should explore more of such agreements with Roche beyond just Herceptin and including other molecules and for other cancers as well. Thank you.
So we may need special arrangements. Yes.
Yes. I was just going to say, with the supply chain with regards to drugs, with regards to childhood cancers, fortunately, the WHO with other partners has taken it upon themselves. I mean, Ghana is part of what we call a global platform for access to childhood cancer medicines. So we're looking at early next year, most of the childhood cancer medicines will be available for children, paid for by St. Jude, so they wouldn't it will be free of charge. But we had problems with, I think, the regulatory body, Food and Drugs Authority, because they said some of the drugs had not been approved by FDA. So we really have to work around it and get that approved as soon as possible. So sometimes we put some stumbling blocks, There are drugs that are routine, sort of accepted childhood cancer drugs, nothing new, but that's going to be a bit of a block. But and for that one, it took a bit of a time. I mean, it's taken us almost one whole year to work on it, because we needed to get data as to the children, the drugs that were going to be used, the forecasting, and this is where our data system, so mechanically our pharmacists had to, literally count and come up with all sorts of things. It took us a few months to really be prepared, and it's taken much longer than we thought it would take for us to be able to access this. But it's coming through Ministry of Health. So as I said, if Ministry of Health were to take it upon themselves, rather than leaving it to, as it happens now, private importers to bring drugs, being on scale, and this is going to be, it's an MOU, it's an agreement, so there's a way it's going to be rolled out down to all the facilities, etc. So we need to find a way of pooling in a way that way for all the other drugs, also for the adults, and how to get it to the facilities and at a price that I think they'll be able to afford, and it won't stay on the shelves. Thank you. But it needs a lot of data. That has to be there. We need to work on our data for the other adult cancers as well. Thank you.
Thank you, Prof.
Yeah, the statement by the Roche rep, we've been using the drug, so I can testify to what he said, that it works well. It's gone through the processes. And there's a strict mechanism for making sure that patients who benefit from it, having HER2 positive patients, get the drug. Very systematic. Regarding childhood cancers, I agree, but there's some skepticism. As for free things, even HIV drugs, you see, after a while, now you see where we are. You see, so the system should develop itself so that we can depend upon.
Even when they are free, we can't clear them.
You see, we should depend upon ourselves. This thing of free. One of my colleagues mentioned the Zambia experience. Free, and the whole cancer center collapsed. Now they've sent about 4 or 5, it's even 7, to come to our center to study. People who have been treating cancer already. Because they've been down for about 5 years, because things were free. When it comes to setting up cancer centers, I think that I must provide information. The WHO and the IEA have done a lot of work on the siting of radiotherapy centers in Ghana. They gave us a health economist, did detailed work on where cancer should be sited, depending upon patient flow. Okay, I don't think that we should just jettison that document. It's very important. And the reason why radiotherapy was chosen is that if you look at our history, before establishment of those 2 radiotherapy centers, who gave any chemotherapy in Ghana apart from chemotherapy for drugs, for breast cancer? Nobody was giving any chemotherapy. It was after the establishment of the radiotherapy that people started giving chemotherapy for the other conditions. So the experience is that once you have, that is the difficult aspect of it. The radiotherapy piece in the puzzle is the most difficult aspect of it, to get a comprehensive cancer system. So once you get that, then the other things fit in. Because as for surgery and chemotherapy, it's easier to have the platform. So that is why it is being used. And evidence between comprehensive cancer centers and having one hospital that has all the components of a cancer center, there's no evidence that one is better, outcome is better than the other. People, it's nice people are crazy about because cancer center, because of Mayo Clinic, more faith and so on. Fine. But nobody can show me evidence that outcome is better than a place like, let's say, Kolebu, with all the components, but not in one building. As long as the pieces fit into each other and there's seamless transfer of patients. So you should look at your circumstance. If you have enough money, you are rich, and you can build a new cancer center, there's nothing wrong with it. But if your circumstances say that to be cheaper to go for the second one too, I don't think that you should discourage yourself and think that, oh, you haven't done well because you don't have a cancer center. Thank you.
Thank you very much. It's one here. Prof doesn't like free things. So, Prof, can you pay for your lunch?
Thank you for the opportunity. I'm looking at the long-term measure. Is it possible we can equip our local pharmaceutical companies so that they can go into manufacturing these drugs? If it's tax waiver, we will give them so that they can import the raw materials. If it's about equipping their companies, if it's about upgrading their skills, can we do that so that locally we can produce some of these oncology medications other than always relying on external sources? Thank you.
Excellent point. Domestic manufacturing, any reaction, is that not something that our local pharmaceutical companies can be encouraged to do? Yes.
Yeah, so just before I go into, but just to touch on the local manufacturing, yes, it's possible, except that there are a lot of systems that need to be built. The cost of manufacturing local oncology products really is huge, and if you don't have the markets to be able to really reach out to or sell to, then the cost of production and all of that would defeat the purpose of local manufacturing to make sure the prices come down. And so it goes beyond the manufacturers to ensure that within the African region or within maybe our West Africa, for instance, we make it easier for those local manufacturers to go beyond the Ghana market, which is a smaller market, and reach out to other. I know there are initiatives currently going on, being led by African CDC and some other. So
let's consider.
So we should consider beyond Ghana as a market, making it easier for them to target the bigger markets. But still on the food procurement issues, just to address the issue that Ross raised. So the point is that in doing the food procurement, we are looking at those basic chemotherapies, basic oncology drugs. That's just one single organization or company like Roche may not necessarily be playing within that space. We are looking at the broader basic chemotherapy, because it's a shame that for some of those basic medications that even when you go to high income countries, they are not even considering. It's difficult to even get those ones consistently available within our system. So definitely there's room for products like Herceptin and the likes, but on the broader issues of those chemos, we definitely need the food procurement system to be supported. And I think that since it's a ministry program, we should push this agenda and get the guarantee from the Ghana Medical Trust Fund that they are going to pay for these medications, and that should be able to attract suppliers to want to be part of this. Thank you.
Private sector, they see money. Yes. We'll take one or two more. Dr. Bafoba.
I think what is on the table now is the food procurement. And this was started, I think, 2-3 years ago. So ministry has to pick this up. And I want to add that it's not only drugs. Surgical sutures, anesthesia drugs. The last time we met, it was like anesthetic agents were the major driver of surgical costs. So when we are doing procurement, it should be across board. We need to consult all the other players to know, where they also fit into the procurement, so that we can help drive down costs instead of always thinking that we need to move up. So the procurement is what should be, the way to go. Thank you very much.
Well, don't forget the local manufacturing. It may take time, but we need to start now. So.
All right.
Good. So now I'll come to my panelists. I've hijacked your...
I think it's been a good discussion. So maybe I'll just summarize what everyone said. That in thinking about setting up new oncology sites or strengthening what we have now, as in the teaching hospitals or the other private oncology sites, that's a discussion to have. In setting up new oncology sites, I think Prof. Yani brought in the last one about the fact that IEA and WHO has done a lot of work as to where radiotherapy should be set up. And since radiotherapy is key for oncology treatment, we can't just set it up anywhere. That documentation has to be looked at. Human resource is key. Human resource in terms of radiation oncologists, medical oncologists, which may be coming on, surgeons, nurses, palliative care personnel. So human resource is key in terms of setting that up. Traditional healers should be brought on board early. And also going back to the Friday, siting should be scientific. When we bring in human resource, you should find ways of sustaining their staying at the sites. And then sustaining equipment. Interruption of cancer care should not be. I still remember some of our patients who start radiotherapy and then the machine breaks down, they start and then it breaks down. It takes longer than it's necessary for them to complete their radiotherapy. So we should sustain our equipment so that interruptions to cancer management is reduced. Then came supply chain. Food procurement should be looked at again. There are challenges, but obviously talking through the challenges can make it possible. The good thing for childhood cancer is that someone is going to pay for the drugs, but free is not. We should look at free things and see how we can sustain this free cancer drugs for a while. So I guess that sums up our discussion.
I'd just like to add that I think whilst we are talking about all of this, the public-private partnership, I think we should be really looking into that space a lot more, because not only just working with the private pharmaceutical companies but with NGOs who are interested in supporting this, even individuals. I know Ghanaians like to be tagged with having supported something. People go out to donate. What about even for a radiotherapy center, a radiotherapy machine? You could have probably a private individual or others come together and decide that this is something they would like to do for, to be associated with having provided for. So maybe if we go out and let them understand the possibilities that we have, in addition to, the Ghana Medical Trust Fund will also be doing that. But I think this is something we should be looking into a lot more. Thank you.
I think in the area of palliative care, we came to a consensus that there's the need for development of a policy to guide palliative care provision in the country. There should be education at all levels to ensure that palliative care is integrated at all levels and not just at specialty levels. In terms of home-based care, there's a need for regulation of home-based care, who does what, prescriptions, at what level, regulatory bodies interested in how home-based care is being provided at all levels. So we also talked about communication, effective communication to patients at all levels, especially when palliative care is involved, letting healthcare workers know their roles and how there could be feedback, bi-directional feedback for patient care. And I think that we ended up with a point that was not expanded, but community involvement, involving religious workers, traditional attendants, all those being involved in the care, especially even informal caregiver education on how to take care of patients who need palliative care. Thank you.
So just to add on to what has just been said, I think in all this, when it comes to palliative care, let's always remember that late referral isn't the best for all of us. Early referral is what we are preaching, and we want that to happen. When you look at home-based care, let's make sure the people being sent to our homes, the homes of Ghanaians, are the right people doing the right thing. Because there are so many things happening out there, and we need to work as fast as we can to get these people together, monitor them, know what they are doing. And also our family caregivers must never be left out. They feel very, very devastated, even when they want to be part of us, they are part of the care, they are devastated. When you leave them out, they are devastated. So how best do we come together, get them involved, support them, train them? Because most of the things they are doing, they don't even have any training. They just do what they can do for their relatives, just to make them comfortable, because they don't want to see them suffer. And with the treatment, I think all has been said. I'm still on the point that let's not rush into doing things we cannot maintain. Sustaining whatever is going to be done is the best thing to do. We have the human resource, and we need to ensure that we make use of what we have in the country. And there was an important point that was raised, and I was happy about that, the brain drain issue. It's not the best for us. We have the people, but they are going out there and then providing the services out there. So it's something we need to look at, irrespective of whether it's palliative care or oncology care or any other care. Thank you very much.
Thank you very much. On your behalf, I really want to thank the all-female team for...
Fantastic, fantastic.
Thank you very much.
So thank you. We're doing so well, and let's clap for ourselves. We are doing fantastic. So far, so good. We are running up. It's very, very important segment coming up. I need to go to the bathroom, so all of you. Oh, If we can kindly take our seats, ladies and gentlemen, so that we can invite Dr. Hafiz Adam to lead us in the presentation of the draft roadmap, the discussion of that roadmap. So if you could please take our seats. I'll mention names. Watch your cancer. Sit down. I'm not sure about mentioning Sophie Bosman's name. I don't think I can mention Sophie Bosman's name. With Dr. Philip Anderson. Great. Thank you so very much. Now, a very, very important juncture in this maiden cancer forum for our dear nation, Ghana, and for ourselves. It's interesting how we always talk about patients, but here we are all patients and families. And so I'd like to invite Dr. Hafiz Adam Tahir to please come and lead us in a discussion on the draft roadmap of all of our discussions so far. Thank you. Could you?
Thank you very much, Dr. Chair, distinguished ladies and gentlemen. Okay. Yeah, I'm sorry. Yes. So we've come to the end of our 2 days forum, and since yesterday, I remember the frustration and the doubt whether after this, all the things that we have said and done will not go to gather dust. So by way of showing evidence, we'll look at some strategic areas that we have captured. We've also stated the key things that we should be doing. Alongside, we have the timelines, and then the lead organizations or personalities that should be in the forefront implementing them. So, Prof, be rest assured that it will not be one of those as you described it yesterday. So, Mr. Chair, first of all, we'll look at the stakeholder mapping. It was said yesterday that we needed to look at our stakeholders, and so we'll do the mapping. We'll conduct the comprehensive stakeholder mapping. And then it will include our donor or development partners. It will include the NGOs, CSOs, the pharmaceutical companies, and several others. And the intention is that with this, by the end of February next year, we should have seen this done or implemented. So that's the timeline for it. Now, the lead organization will be the Ministry of Health, Ghana Health Service, and development partners. We'll also be making, apart from the mapping, we'll do the awareness creation, and we'll assign responsibilities to all those who will be involved. The next thing that we'll be doing is to maintain the National Cancer Platform. I'm sure most of you are on it. If you are not on it, and you think you are key to this, please make sure that you are included. So we'll maintain it for ease of dissemination of information, even as we live here. We know sometimes you live here and you start thinking about other new things, and so it's available, we'll maintain it in order that we'll continue to harvest ideas as we finalize this thing. And so those that will be responsible, the agencies or the institutions that will be involved will be NCCF, development partners, and of course, Ministry of Health. Then the next thing is to do impact assessment of previous strategy, because we're told it exists and then we'll need to evaluate it based on current circumstances and situation to see whether it's fit for purpose or we'll have to review it. And we are thinking that by the end of February, we should be able to finish with the impact. And that one will be involving the WHO to support, including Ministry of Health. Then the other thing we'll be looking at is the sustainable financing and resource mobilization, which was also key. And so here we are looking at the National Health Insurance Scheme, and we're also looking at the free primary health care awareness creation and early detection issues, then the human development on prevention, and then we also the specialized care, human resource development infrastructure. These are all captured under this sustainable financing and resource mobilization. And we are looking at of course, Ministry of Finance will be involved, the NHIA, Ministry of Health, and our development partners. The other things we'll be looking at will be the revision of National Cancer Prevention and Control Strategy. We need to look at the possibility of updating it based on the impact assessment. And that one, we are thinking that by September next year, we should be done with that. The other thing we have captured will be the harmonization of cancer guidelines across all levels. It came out strongly. And so the standardization of protocols for awareness and early detection, diagnosis will be the components of this part. And tentatively, we are saying that by April 2026, we should be able to deal with it. So those that will be involved will be Ministry of Health, Ghana Health Service, professionals, colleges, and partners. The other thing has to do with the implementation options. That's the PPP. I think yesterday I alluded to the fact that we are advancing and taking to a different level the PPP that we have been carrying on. And this time, even including infrastructure, and we've said it, that even the Agenda 111, we are looking at those that are at a certain advanced level that we need to just do little or need to use to put it to use. But for those who are in the middle and just at the starting point, organization and private partners who will come on board to engage us to develop it, our doors are open. Now also look at the streaming Ministry of Health partner engagement to reduce the bureaucratic tendencies, as yesterday it was reported. And sometimes yesterday when it was said, I was wondering, because we have various open entrances to the Ministry of Health. So when you write to the minister, say to the minister, silently you could engage the division or directorate that will be responsible for that, so that that director or that directorate can be following up on your behalf. But if you write it to minister and it has to do maybe with the procurement, and the director of procurement is not aware, and because of the overwhelming documents or things that the minister will see, it will be there. And that's where you start seeing the frustration. So I would advise that if you want to engage the minister and you write to the minister or the chief director, just have it in mind that you may have to silently engage the sector directorate that will be handling it, then it will be fast-tracked. Coordination strategy and implementation. Core strategy implementation activities, we'll be looking at the M&E framework with KPIs. We also secure dedicated implementation funding. And so with that, our timeline will be November 2026, hopefully, and that will involve, as I said, will be led by the Ministry of Health. Then the Cancer Data Registry. We are aware that we've been talking about this, but it all has to do with some funding. And so we are looking at partnering with development partners to make sure that they support us. We know at the various health facilities, they have their pieces of the data, but we need to mobilize and have a unified cancer registry for the nation. And that will be done, and we are thinking that by June 2026, we should be able to implement. And we emphasize in getting the faith-based organizations. So CHAG will be playing a major role under this, including private partners and the teaching hospitals. You will be very much involved in this. We've talked of palliative care, pain control. So we'll be looking at the palliative care policy strategy, institutional care, and then also home-based care, regulation, and formalizing the informal caregivers. And we also talk about the guidelines, what should be guiding their rules. That will be asking the private sector to be involved in this. Then end of life, which we discussed this afternoon, the levels of care, we want to make sure that we look at it, and the management. Then we also, the palliative care awareness, we think that we have to do more in terms of education and communication. The remuneration for caregivers, all these things have to be streamlined. Because we are not certain yet exactly what we'll be doing, we haven't put timelines so that you will not be holding us to it and we can explain. The treatment cost, NHIE, as we said, we are also looking at the association groups, community fund mobilization. These are all parts of what we'll be looking at in terms of treatment costs, what should cover. Then treatment and radiotherapy centers and their siting. I think this afternoon we heard a lot about it. So we'll go back and look at what was captured as a baseline, the support the WHO gave, as said by Prof, that is available. So we'll look at it to make sure that equitable infrastructure in terms of geography will strengthen the existing facilities. We won't forget about the human resource, equipment, maintenance, sustainability, and that's where the PPP comes in strongly. And that one, private partners will be involved, our development partners will be involved in this. Then the last will be the medications. Medications, there's a need for local manufacturing, yes, and you are aware that we are partnering with private sector, even as we speak about the production of vaccines. I think we'll include the oncology consumables and medicines as part of what we'll be doing. We have started, but at a lower level, but I know that eventually it will capture all these sectors. So indeed, we're on our way to make sure that is done. So we'll also look at the pool procurement system and then the supply chain. We are thinking that we haven't fixed demand, but we are sure that by 2026, we should be able to realize this. And Minister of Health will be spearheading this. On this note, let me thank you very much for what we have done for the past 2 days. Thank you.
So, Dr. Chair, I'm not sure if there are any, maybe 1 or 2 pressing clarifications or discussions on any of the areas that you've heard so far. Maybe we can take them. Because it's supposed to be a discussion. This is ours. It's not just the Ministry of Health. This is our roadmap. So once we move out of here, we've all contributed to this. Okay. So shall we? So, Dr. Kunedu, the communique, I think initially the discussions were already had, yes. So that we are done. The key things are what we've had so far. So for now, it's time to listen to the Chairman General. Everybody's waiting for the closing remarks. Because yesterday, we had extensive closing remarks, and I said, this is why you should just go see him and take his notes. The rapporteurs don't need to do anything again. So we invite him to give his closing remarks.
I was asking how long.
Please don't tell him my answer.
Colleagues, we've come to the end of our first historic National Cancer Forum. I wasn't part of the organization. I heard about this forum exactly a week ago, so I was roped in the last minute, but on your behalf, I really want to thank the organizers for a well-organized summit. The question for me is, did we achieve the objectives we set up for ourselves? I've been asked to reflect a little bit on that, and I promise I will not be too long. It may only take 90 minutes. Our first objective was to get to know each other. And I think we have achieved that to a large extent. Now I can put faces to some of the famous names, and I'm sure you can do the same. I have made a lot of friends, and I've even discovered 2 new relatives I didn't know. Wow. These days in Ghana, we get to know your relatives when you die. So now everybody knows that the Lumbe's relatives. By the way, I'm in Odobroni's camp. Very soon we will learn about Nana Kuredu Ajiman's relatives. So our first objective we've really achieved. We've established a network, and I hope it will continue. Our second objective was to try and reach a consensus on what are our strengths and our weaknesses, what we call the landscape. And the conclusion was that fortunately we are really not starting from scratch. We've done a lot. Sometimes in our frustration, we don't talk a lot about the wonderful things that have happened on the cancer front, but a lot has happened. We have a plan, treatment guidelines. The last few years, we've trained a lot of oncologists, nurses, pharmacists. But our greatest asset is that we have, as the minister said, brilliant minds, committed institutions, and passionate civil society groups. We have a number of people in the field, and we can learn from them. The visibility of breast cancer and childhood cancer is quite high. And now we have the promise of the Ghana Medical Trust Fund and free primary health care. And there's a promise that some of those monies that they have will go to cancer care. So we have a lot to be proud about. And the icing on the cake is that we even now have a forum where we can insult each other. I hope we don't learn from Efia Schwarzenegger, Kevin Taylor, and Abronye. So, but we also all agree that we have a number of challenges, and I will not go through many of them. But just to remind ourselves, one big area is about leadership. And we all complain about how the Ministry of Health has been a problem. And obviously they are now going to be part of the solution. How Ghana Health Service, for example, is too addicted to infectious diseases. and how partners like raising their flags and the media. We also talked about problems in governance, no clear direction, the need for milestones and KPIs. And as we heard, we need to quickly map out who is doing what and where. Of course, we also talk a little about prevention, that we appear not to be doing a lot in that area. And we talked about, at least we've done something in immunization. But when it comes to lifestyle and diets, we're not doing too well. Addressing carcinogens in our environment is also an area you don't hear a lot about. In Ghana today, alcohol is promoted as bitters. Not as alcohol, but as bitters. And it's supposed to also improve sexual performance. Moyare. There was a lot of discussion on early detection and the need for high index of suspicion and clinical diagnosis, but one of the big areas we all talked about was diagnostic capacity. There is a problem there, and it's also include lab. And of course, this is one area where we all agree that PPP can carry some promise. Retooling and all that, cancer medicines, the integration of services. And today we spent quite some time on palliative care, so I will not go to that. The need for us to be family-centered. Workforce is very important. We don't have enough. And we need to make sure that not only do we train more, we also provide incentives to retain them. I heard and learned a lot about navigation. We talked a little about finance, a lot about financing, and we advise that financing must be sustainable, sustained, but also reliable. And government alone cannot provide all the funds, so we should also explore initiatives like the NAT and the Ghana Registered Nurses and Midwives program. Today we spend some time on health information, the need for local data. I was disappointed that a lot of the data the minister and the chief director quoted were global data. We need to invest more in our local data. We have a good start with 2 functional registers, but we need to have the commitment, and the proposal was to have a dedicated group to look at that. Because as we know now, we have the LIMS is in limbo and is giving way to GIPS. So, as you've just heard, because of all these problems, and in Ghana we don't say they're problems, they are challenges. Because of all these challenges, we've come up with a roadmap. This roadmap was put up in a very short time, so I'm sure we'll consider that as organic. And if you have any other comments, please make sure you help us improve on that. So that leads me to our third objective. It was to begin the journey to develop a revised 5-year national cancer strategy. And as I said, the roadmap is the beginning. But in order to move forward, we learned today the key is the multi-sectorial partnership. A lot of government agencies, private organizations have something to offer in this area. And sometimes we need to go to them to understand what they have to offer. We learned, for example, that the Ministry of Education can help with curriculum development so that we can catch Ghanaians when they are young and not when they are old. The other thing we learned is that, yes, Ghanaians do not trust their politicians, but we trust our pastors and our imams. And therefore, they can also serve as a vehicle to help us do that. We heard about EPA and also CSOs. They can make noise where we cannot. And they can open doors we cannot open. So it's important that we see CSOs not as enemies or competitors. They are really collaborators. So we need to move away from where an NGO is essentially anti-government. And of course, the private sector organizations can help us improve on many other things. So that leads me to a few comments on the organization of the meeting itself. As I said, I wasn't part of the design, but it's gone very well. It looks like, and these are comments. The two MCs have done excellent work.
More money.
Yeah. It looks like this is an ideal venue. The food was good. The snacks were not too healthy. But we had excellent presentations and moderators, and I have been really impressed with the participation. We very open and frank, but friendly. No insults. We expected the minister, but he could not come. But the deputy minister was here with us. The chief director is here. So the leadership of the ministry is with us. I was also very happy that almost all the regional directors from Ghana Health Service are here. I learned many years ago that if you want something to be done in Ghana Health Service, go to the regional directors. They are the people who can make things happen. Just provide them with a little oil and things will happen. But we also have very open CSOs who have really done a lot of work in the field. And it's important that we do not reinvent the wheel. We should build on what they've done and make sure that we can replicate that nationally. And I was very happy with the spirit of the discussion. Very, as I said, very, very open. So I look forward to an even better organized summit next year. And I leave you with the words of the minister. We must be bold. We must be united. Let us make history. The future depends on what we do in the present. Thank you, and God bless you. And I'm thanking myself, so you don't have to thank me.
So thank you, Senior AB. Fantastic. Like I said, we'll come for the notes. Everything is in there. Someone has been hiding, and I have been told that she has been hiding, and we have found her. And he says, no. Professor Lydia Aziato, Vice Chancellor, UHAS. This is the citadel of being self-actualization. When you come, you hide. It means you are there, and still will find you. May we get to that point.
Ladies and gentlemen, you all agree with me that this 2-day cancer forum has been very impactful. And as such, we need to acknowledge some individuals and groups whose collective efforts have ensured the success of this program, just like our Dr. Chair mentioned. And we have someone well pleased to do that. So help me as we welcome to the stage Dr. Ernest Esiedu-Knedu to do that for us.
Thank you very much. You didn't say I shouldn't thank you. Okay, so distinguished ladies and gentlemen, I would like to thank all of you for the participation. I think Chairman has mentioned that. And as we have our own religious diversity, first we want to thank the Almighty God for giving us the 2 days. We haven't had any issues. In fact, initially we were a little bit scared with the numbers, but I think it has been quite impressive. And so, Chair, we thank you very much for steering the whole affairs. Even though you can give a little summary, it captures everything that we did. Let's put our hands together for Chairman. He's a Chairman General, so, and I'm really impressed, always taking after his steps. And I hope that one day, when I retire, you find me home like this. Okay, so we also want to thank the Honorable Minister. I think he was also engaged in another very important meeting. You recall that GMA had the Congress last week, and also RNMA, also having their Congress this week. So you can imagine the antagonism. So we agree 100% that he could not join us in person, and that the Deputy Minister for Health was also here. And then the advisor for the Honorable Minister has been here for 2 days. I'm sure we saw him again. And the Chief Director himself was also here, and we thank all of them. Various representatives from the other ministries that we talked about, especially around the intersectoral collaboration, were also represented, and we thank them very much. And then the Vice Chancellor, at least we are blessed to also have a Vice Chancellor from a university. I think that we have recognized Professor Lydia Aziato. That also shows how mighty this particular program is. And then the various heads of agencies and the CEOs, from our teaching hospitals and from our various institutions were also here, and we thank them very much. And the directors of the Ministry of Health and other agencies were also present, and we are very grateful for their time. And let me just say something small about the regional directors especially. We do know that every partner or every CSO or every organization doing something within our space would ultimately happen in a certain region, and ultimately, since they have oversight over the various districts, we hope that as part of the mapping process, they would assist us in mapping all the stakeholders within the cancer space in their regions that will go into the districts, into the sub-districts, and it will form part of the national stakeholder mapping activity that we are doing. We also want to thank our development partners, all of them who are here, especially some of our sponsors, CCAN and GIZ, Pfizer Foundation, Japaigo, Roche, CHAI is also here, World Child Cancer, Johnson & Johnson also joined us, and then also Siemens that have supported making this particular program a success. We do want to thank our religious that are here from the Office of the Chief Imam, from the Christian Council, and then also the traditional team that also came around. There are various CSOs and NGOs that have also supported us, and we thank them. And also within the private sector, we also want to thank the Sweden Ghana Medical Center, which is currently, I would say, the only private comprehensive cancer treatment center. They've also made themselves available, especially when you invite the private sector. Whilst they are sitting here, sometimes they are patients. For them to spend the 2 days together with his team coming here, we do respect that. And we know that there's real collaboration between the public and the private sector towards the direction of making sure that we can fight the menace of cancer holistically. Distinguished ladies and gentlemen, we want to thank also the media that also showed presence. We've been able to stream this whole thing live on Facebook and other media platforms. We thank the IT team at the back. They have been very, very instrumental, making sure that everything has gone well. And finally, I think Chairman has also recognized the role that the hotel, very good destination for us coming here. And we thank the hotel for assisting us and supporting us and offering their place for us to do We also want to thank our online participants. Normally, it's not very easy to stay online, especially there will be snack break. You have to break and go for your own snack. There will be lunch. You have to break and go for your own lunch. And if there are some other funny jokes, sometimes you miss them. But they've been very consistent, made a lot of inputs for enriching this particular meeting. We thank them. And then, but not the least, I want to thank the Technical Coordination Directorate, led by our own Technical Coordinating Director, Dr. Hafiz Adam Taher. Let's put our hands together for him. The entire team of the Technical Coordination Directorate, and then also the various sleepless nights. It hasn't been easy. Even the last 2 days, most of my staff, we didn't sleep. And I want to thank all of them. And especially the Cancer Planning Committee that is made up of Ministry of Health staff, private sector, CSOs, the development partners, and all the stakeholders who have worked tirelessly to make this happen this time. We are hoping that this is going to be an annual thing, and the planning for next year's one is going to start from this afternoon. And we are hoping that the platform that we had in planning this, we are going to beef it up with all of us here. And living here, we are expressing our own commitment towards making sure that in the next 5 years, the narrative of cancer care in this country will be different. I know that I'm also going to retire. In fact, most of my colleagues who are here, we are also going to retire soon to join as seniors. And if we do not do anything now, we will forever hold our peace. We cannot complain about a health system that we have been part of. We have risen to a certain level to be able to make an impact. Thank you all, distinguished ladies and gentlemen.
Okay, this is it. We're done. My job is done. I'm going to collect my envelope. See you later. But before we go, let's all be on our feet as the personal assistant to His Eminence, the National Chief Imam, leads us in prayer. Doc, the no, dear, we will accept the no.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Ya Allah, we thank you for the opportunity to gather here to discuss an important matter in relation to the health of the nation. We ask you to grant us the wisdom to appreciate this project as a collective responsibility and a civic duty. Ya Allah, as we bring this program to an end, let your blessing be on all of us until we return home or get back to other destinations. آمنا بالله واعتصمنا بالله وتوكلنا على الله ولا حول ولا قوة إلا بالله والصلاة والسلام على رسول الله وآخر دعوانا أن الحمد لله سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين آمين.
So much. Ladies and gentlemen, this is it. Please, the next one will be in Kumasi. Mupo, you have to come to Kumasi. And please, guys, you didn't feel, we can take a photo. You didn't fill the evaluation form. Only how many? How many so far? 30. Hey, that's a quick now, so per se. And that's a good sample size. Yay, Bermena. It's a 30 then KO. All right, let's take a group photo before we go for lunch, please. Boss, please come forward and let's take a group photograph. Group photograph, please.
Yes,